Okay, so recalls for September 2019. Question number 1 is, a lady after elective cesarean section due to breech presentation wants to discuss with you about vaginal seeding. What would you tell her? A. Bonding is increased. B. Exposes the neonate to infection. C. Improves cognitive ability of the neonate. D. Prevents from atrophy as a child. So here the correct answer is B, because this is a traditional practice. People think that babies who are born through the vaginal route, they are healthier as compared to the babies which are born through the abdominal route. This is true when it comes to transient tachypnea of the newborn baby. But when it comes to infections and the vaginal secretions, then we need to tell the patient that there is no medical evidence that it will improve immunity of the baby. Rather, it is going to increase their risk of developing infections. So what they used to do, that baby is born through by cesarean section, so they used to smear the body of the baby with vaginal secretions. They thought that it will make the baby healthy, but actually it exposes the baby to more infections. Then second thing that incidence of TTPN is low in cases of vaginal delivery, because once the baby passes through the birth canal, all extra fluid in the lungs, it will be squeezed out. While in the babies which are born through cesarean section, this fluid is retained in the lungs. So these babies are more prone to develop RDS. That is the point. So besides that, no evidence of any benefit for the baby. So the question they are writing, that what is vaginal seeding? So then the same thing, that smear the baby with the vaginal secretions, but no benefit of any, no evidence of any benefit. And then remember, maybe they will repeat this question, or maybe they will give you another question, because they are always updating their questions. And this information was taken from British Medical Journal, BMJ. Okay. Question number 2. Patient with uterine prolapse who is also attending infertility clinic, she will require which of the following procedures? So the patient has uterine prolapse. Sacrocarpopexy. Carpus is the name for vagina. So here she has uterine prolapse. So we have to do hysterocarpopexy. That is the recommended treatment. And when do we do this sacrocarpopexy? When your patient has vault prolapse. When do we do anterior carporrhaphy? If your patient has a cystocele. And we don't use the words cystocele or rectocele anymore. We will say anterior carporrhaphy if your patient has anterior vaginal wall prolapse. And posterior carporrhaphy if your patient has posterior vaginal wall prolapse. Posterior vaginal prolapse. Sacrospinous fixation also is done either as a prevention for vault prolapse or as a treatment of vault prolapse if the woman is not sexually active or she is unfit to undergo any abdominal procedure. So here they said that this was vault prolapse after hysterectomy, 75 years old patient, previous 3 sections, also 1 laparotomy due to benign ovarian cyst rupture. So what is the most suitable first line surgical management? So surgical management, again it will be sacrocarpopexy. You can change the route if she is sexually active. If she is not sexually active, then your answer will be sacrospinous fixation. That is the discriminating point. So if you have a patient who has history of multiple operations, then we don't abandon the next procedure. You will just call someone who is more experienced, and so that they have better surgical skill, so they can do the procedures. And then even in the low risk patient, you can encounter many difficulties, like they can also have injuries to the urological system, injuries to the this GIT, or injury to pelvic viscera. So risk is always there. Medical care is a high risk business. Risk is always there, but you have to counsel the patient appropriately regarding the risks. In this scenario, I have seen this question in different ways, in different backgrounds. Sometimes they will give you this question, that can we do this laparoscopic sacrocarpopexy? So I won't agree for laparoscopic procedure because this patient is going to have multiple adhesions. But we can do this open abdominal sacrocolpopexy. So if they don't give you an option of doing this abdominal sacrocolpopexy and they are adamant that you should be doing laparoscopic procedure, then instead of using the routine approach, like you are going through the primary port is going through the umbilicus and the secondary ports are going from the lateral sides, you will do Palmer's point entry, and you can use Hazen's technique, but still you can do a lot. Even with the fiercely, severely frozen pelvis, still you can do many things. It will take a longer time and high chance of having injuries, but still you can do that. If your patient is sexually active, don't offer this sacrospinous fixation. This sexual activity is considered one of the parameters of normal healthy living. So if it is compromised, they will say that you are compromising quality of life of patient, which is scored very appreciated very highly. So don't do that. Adopt alternative routes. Okay. So question number 4, type of carcinoma associated with endometriosis. So let's go over these cancers. Endodermal sinus tumor, what type of cancer is this one? Any one of you? Yolk sac tumor. So this is a germ cell tumor. What is the tumor marker? Alpha fetoprotein. Alpha fetoprotein. From where you are getting this alpha fetoprotein? From placenta and from the fetal liver, or from the liver of the patient, and then from the this placenta in the embryonic life, and from the it is coming from the tumor if your patient is an adult. Okay, so it is coming from there. So what about clear cell carcinoma? So women with endometriosis, they have a 3% chance of developing clear cell or endometrioid type of clear cell is 3%. That is the highest incidence. Okay, and endometrioid tumors. Endometrioid type of tumors you can see in the uterus and you can also see in the ovaries. So here they are writing that around 25%, but when we compared many studies, we found that the incidence, if one patient is getting endometrioid carcinoma, compared to that 3 patients are developing clear cell carcinoma. So it is not as common as clear cell carcinoma. Clear cell carcinoma is 3 times more common. So this is not the answer. So this is true that there can be an association with the Heredia1 gene, but here in cases of clear cell carcinoma, in cases of endometriosis, clear cell carcinoma, its incidence is much higher than incidence of endometrioid tumor. That is one thing. Okay. Next question. Lady is with lady with estradiol level of 200. So this is associated with which type of tumor? So it is associated with, as you know, with the granulosa cell tumor. So granulosa cell tumor, this is not a germ cell tumor. What type of tumor is this one? This is a sex cord tumor. Sex cord tumor. If they ask granulosa cell tumor, so it produces estrogen. So and then it has a bimodal distribution, highest incidence in the pre-pubertal girls and also or in adolescents like before the age of 16, and then in the post-menopausal women mostly in their 60s or 70s. So this is a theca sex cord tumor. If they ask you that which is the most common germ cell tumor, your answer is dysgerminoma. That is the most common germ cell tumor, and the like 50% of the germ cell tumors, they will be dysgerminomas. 10% chance that dysgerminoma will be bilateral. Okay, so granulosa cell tumor, this is a sex cord tumor. It produces estrogen. Patient can present with precocious puberty. Then they will ask you that we have seen Paul Exner bodies, so which type of tumor patient has? Again your answer is granulosa cell tumor. Now what do you understand by Cole-Exner bodies? What happens is that in the tumor tissue, you are going to see blood vessels, small blood vessels, and the tumor cells, they will be scattered around these blood vessels. And these cells, some of them, they will be hemolyzed, the broken cells, okay? So they will look like petals of a rose. So we say that these are flower-like arrangements around blood vessels, and they will give a pinkish appearance to the histopathological specimen. So those are granulosa cell tumors. They are specific for granulosa cell tumors, so these are called axillary bodies. Then another type of bodies, Schiller double bodies. I think I told you about that before also. So what are these bodies? Scattered cells in the connective tissue matrix, and they are found in seminoma of the testes. Schiller double bodies, they are found in seminoma testes. So that is the point. Schiller double bodies. Yeah. Yes. Yes. Endodermal sinus tumor, you will get Schiller double bodies. I said so because I told you before. And in case of seminoma, you are going to find crystals. I told you about that also. Rinkies crystals. Okay. Schiller double in, you just revise that one. Schiller double bodies are found in which type of cancer? Which type of endodermal sinal tumor. Schiller double bodies. In seminoma, you are going to find crystals, and the name of those crystals, these are pinkish crystals, and the name of those crystals is Rinkies crystals. Three types of bodies. Then another type of bodies are called seminoma bodies. These are lamellar structures. So these are found, you will see these bodies if there is medullary carcinoma of the thyroid, and then again in which type of cancer you will find them? Seminoma bodies. Epithelial cancers of the ovary. Okay, so usually they will ask you questions about these four structures. So any doubt, any confusion about these bodies? Cole-Exner in the granulosa cell tumors. Schiller double bodies if patient has embryonal cell or embryonoma or yolk cell tumors. Seminoma testes, you are going to find Rinkies crystals. Seminoma bodies if your patient has medullary carcinoma of the thyroid or she has epithelial tumor of the ovaries. And sometimes these the patient can present with different multi-endocrine syndromes. So what will happen in those cases? They can have carcinoma of the thyroid, parathyroid, and ovaries. So in all of these three, medullary these seminoma bodies can be seen. That is the point. Okay. So any confusion so far? Okay. Question number 6. Postmenopausal women with 10 millimeter endometrial thickness. So what is the increased risk of? So now she has endometrial hyperplasia, thick endometrium. So do you think that she can have this endometrial cancer? Yeah, can be endometrial cancer. Yeah, can be granulosa cell tumor. So they chose here this B, but if you will ask me, we will go for endometrial carcinoma, because everywhere you must have seen that if endometrial thickness is more than 5 millimeter, we have to think about endometrial malignancy. Okay, so this one is more common than the granulosa cell tumor. So answer here will be A, endometrial carcinoma. The chance of endometrial carcinoma, yeah. In this question, yeah, yeah. In this question, this is question number 6. If you pay attention, if there is estradiol, then you have no option. Then you will go for granulosa cell tumor because it is going to be there. Okay. If they don't give you that estradiol level, and they will tell you that this woman is postmenopausal and she has 10 millimeter endometrial thickness. So basically, whenever you suspect some malignancy, you will have to see that what are the risk factors in the history of this patient. This is postmenopausal, and endometrium should be thin. There should be atrophic endometrium. But if she is not having thin endometrium, then it means that she has some elements which are causing growth of this cancer. If we will go over the etiology of endometrial cancer, then you know that obesity is the greatest risk. The chance of developing endometrial cancer will increase by 30%. And then in obese patient, from where you are getting these estrogen, it is coming from the fat tissue by peripheral conversion of androgens. Okay, androgens are converted by aromatization. They will be changed into estrogen. So peripheral estrogen, and this carcinoma can develop. Then if your patient is diabetic or hypertensive, or she has history of PCOS, it will also increase their risk of developing endometrial cancer. If your patient is a smoker, then this smoking is going to decrease her risk of developing endometrial cancer, because this nicotine is anti-proliferation, so it will cause that is, it has anti-estrogenic properties, so it will cause endometrial atrophy. So smokers, they can have menopause by 1 or 2 years earlier than their age matched counterparts. So here, here they didn't give you any level, because all information they have presented here is, just remember that these are recalls. We have no clue to the actual question. Okay, so this is postmenopausal, endometrial thickness 10 millimeter, so increased risk of endometrial cancer, that is the number 1 option. If they tell you that there is plenty of estrogen in her system, then you will say that this is granulosa cell tumor, because they have detected it. Or then this granulosa cell tumor, it is a tumor of the ovaries, not a tumor of the endometrium. That is the point. Then there is a lot of confusion about thickness of endometrium. So different colleges are using different cutoffs. Some say that 3 centimeter, 3 millimeter, 5 millimeter, and then 9 millimeter, and then this 10 millimeter. American and the Canadian societies, they say that if the endometrial thickness is up to 9 millimeter and your patient is asymptomatic, then you can leave her alone. But the moment it increases to 10 millimeter, you have to take a biopsy, and then you need full assessment of this patient. Then exceptions to this situation can be if your patient is taking tamoxifen. So tamoxifen and raloxifene, what type of drugs are they? Anti-estrogen, estrogen receptor modulators. That is the proper name, right? Estrogen receptors modulator. Use appropriate name for the finding the correct answer. Can you tell me about progesterone receptor modulator? You know about that. We talked about it before. Excellent. Julie Bristol acetate. Excellent. Okay. That is progesterone receptor modulator. So tamoxifen and raloxifene, they are sisters because they belong to the same family, estrogen receptors modulators, but their effects are different. Both are going to decrease the chance of development of this breast cancer, so that's why they are given as adjuvant therapy, not as the main therapy. Adjuvant therapy in cases of breast cancer. On breast, they have similar actions, but on endometrial proliferation, they have different actions. Raloxifene is going to inhibit growth of endometrial tissue, and tamoxifen is going to enhance growth of endometrial lining of the uterus. So if your patient is on tamoxifen and then you find that thickness of endometrium is more than 2 centimeter or more than 20 millimeter, then you need to take the sample. Before that, you don't have to do anything. Some books say that if your patient becomes symptomatic, like she has bleeding and endometrial thickness is like up to 2.5 centimeter or 25 millimeter, then you need to biopsy her. So the standard recommendations are that when you have a patient who is on tamoxifen therapy, then every 3 months you have to do the transvaginal scan to check the endometrial thickness. And then you need to tell your patient that if she's having intermenstrual bleeding, like any type of abnormal bleeding, then she needs to report to her oncologist. That is the point. So if in the exam you get someone who is having bleeding on tamoxifen, then you have to reassure them. You don't have to treat them for that because the cause is different. Cause is tamoxifen. Chance is low, but still it can occur. That is the point. So that is the correct answer. Chance of endometrial cancer will increase. So we need to tell the patient about that. Okay, that we need to biopsy her, and after that, if nothing is found, then she's fine. No, you don't have to follow her up. But if she is symptomatic, then you will have to, or you find abnormal pathology, then you have to treat that. Any confusion, any issues, any concerns? Okay. If you are not happy with any answer, then write the question number and write down your answer, and we can always talk about that one. Okay, this is interactive, so you don't have to rely on me. If you have some alternative answer and alternative explanation, just tell me about that. So similarly, this reminds me that if you have someone who has osteoporosis and she is unfit to take, she's in the postmenopausal group, and she is unfit to take any other medicine, then you can give her raloxifene. So it will also improve her bone health, and at the same time it will not increase her risk of developing endometrial cancer, but you cannot give them tamoxifen. Okay. Mm-hmm. Yeah. Yeah, and maybe she's taking raloxifene for the management of breast cancer, so you can avoid polytherapy. Okay, because if one medicine is going to benefit her, then we don't have to add a bisphosphonate or calcitonin, like that. So she's taking one drug, so she's good to go. She can continue taking raloxifene and she's going to be fine, like that. So that's why exam is not checking your bookish knowledge. It is checking your approach also. So if you can treat two conditions with one shot, with one medicine, then you should continue that medicine. No need to change that therapy. That's why when we are talking about osteoporosis, I said that we have to individualize therapies for different individuals according to their lifestyle modification, and then according to their background pathology, according to their history. So that's why we don't give one medicine to 100 patients who are having a similar condition. So you have to change the doses, you have to change the drugs combinations for them. So your question is a good one. You will continue that patient on raloxifene. Don't have to change that. Actually, in medicine, you will make a change only if you think that this intervention is going to help your patient. Otherwise, you don't have to do the things. If they are running smoothly, let them go that way. No need to change anything. Okay, that is the point. Okay. So, so can we go to question number 7? Okay. So, patient had a normal delivery. She is postpartum, SVD, with rheumatoid arthritis. She has raised LFTs and elevated bilirubin and dark urine. So, what exactly she is having? So, as we know from medical knowledge that if a patient has rheumatoid arthritis, she is having an autoimmune disorder, and autoimmune disorders. The problem is that they can present in clusters, because if you will pay attention to HLA-DR3 4 combinations, then we have one combination is there, then your patient is prone to get many disorders. Like HLA-DR3 and 4 is there, your patient is getting rheumatoid arthritis, they can develop type 1 diabetes, they can get primary biliary cirrhosis. So this patient is having primary biliary cirrhosis. About 1/3 cases of rheumatoid arthritis, they can have primary biliary cirrhosis. Autoimmune disease of liver, and what happens, just like in rheumatoid arthritis, we are making antibodies against our own cells. So if patient is positive for primary biliary pharyngitis, then she is going to make antibodies against her own liver tissue, and it may cause cirrhosis also. Then when the liver cells are damaged, then they are going to release liver enzymes, and then your patient can develop this one. There can be picture will be that of hepatitis or like jaundice, like your patient has elevated bilirubin and dark urine is there, dark urine and pale stones. So your answer is primary biliary cholangitis, PBC. Okay. Question number 8. Patient is taking infliximab during pregnancy. So basically, I remember this question that they were asking you that at what duration of pregnancy you should discontinue this drug. So again, what type of drug is an infliximab? Biologics. Yes, anti-TNF. These are biologics, right? So there was many other preparations are also. So who gets these biologics? Autoimmune disorders. Okay. So let's go over them quickly because it's a very common problem. So biologics, it means it encompasses a wide variety of biologic molecules that includes both human and murine monoclonal antibodies and soluble cytokine receptors. Commonly available examples that obstetricians may come across include infliximab, adalimumab, etanercept, and rituximab. All of these are commonly used to treat young women with rheumatic diseases and a breadth of other autoimmune mediated conditions including Crohn's disease, idiopathic thrombocytopenic purpura, psoriasis, and asthma. Common side effects and precautions necessary for pregnant women. This article was published in TOG. So it says that biologics, they have a different classification to their adverse effect profile. Clinicians caring for pregnant women, they will need to be specifically aware of the heightened risk of infections like type C reactions, like immune or cytokine imbalance syndromes. All biologics are potent suppressor of various components or pathways of the immune system. Studies have demonstrated an increased vulnerability to infections. Reactivation of latent infections, particularly TB, it can occur. Hence, guidelines are in place to screen and empirically treat any person at risk of latent TB prior to treatment with any biologic agent, particularly if you are using anti-tumor necrosis factor agents. And infections may present atypically, and there should be a high index of suspicion in screening for infections and aggressively treating any patient with an infection. For similar reasons, it is advised that a person starting any biologics should have all their person should has all vaccinations completed, because any live vaccinations, for example BCG, measles, mumps, rubella, yellow fever, oral polio, and rotavirus vaccinations, they are contraindicated once a person is started on biologics. A woman commencing a biologic agent in pregnancy should undergo the same screening measures and vaccinations as a non-pregnant person, with exception of live vaccinations. Chemoprophylaxis is needed in those with latent TB starting anti-TNF therapy, and this is guided by respiratory physicians. So they should be given sent to the respiratory physician, and usually they are given isoniazid with or without rifampicin. And you should remember that IR, this isoniazid and rifampicin, this combination can be used during pregnancy. Certain malignancies are more common in those receiving anti-TNF therapy, though not currently included in the UK guidelines. Other national guidelines, they advocate screening for cervical cancer prior to commencing anti-TNF therapy. Why? Because cervical cancer is more common in immunocompromised individuals. Commencing anti-TNF therapy in those with a prior history of malignancy and those with pre-malignant conditions, for example, human papillomavirus, it should be undertaken with caution. Pregnancy or the postpartum interval would be ideal window for opportunistic survival screening in women on anti-TNF therapy. So as you know, we don't offer opportunistic therapy, but if your patient is taking anti-tumor necrosis factor therapy, then she can be offered opportunistic cervical screening. If a woman is receiving a biologic infusion for the very first time in the antenatal setting, the team will need to be aware of the risks of immediate hypersensitivity type reaction, type B reactions, and these are rare, like 3 to 5%, but may present as severe bronchospasm. Type A reactions as a result of small release of cytokines are more common and usually present as fever, headache, and myalgias. Fortunately, more recent publications from biologic database bases like they have been reassuring with regard to risk of teratogenicity, and many authors now conclude that the risk of fetal malformations seen they are similar to that of the general population. As you know, this anti-tumor necrosis factor is used in infertility treatments also. So the underlying reason, so they should be they are usually the OB people, they are more comfortable with using anti-tumor necrosis factor like agents in the pregnancy. The underlying reason for this could be that number of fertility services are utilizing it, particularly adalimumab, to attempt to increase the chances of successful outcome by correcting the cytokines imbalance seen in women who require assisted conception. Almost one-third of them, they will have this high level of antibodies, and they can even have this fetal allergy. Okay, when they will conceive, the fetus will be aborted. Okay, so they will be on anti-TNF therapy. Small observational studies from a center have shown that adalimumab, in combination with immunoglobulins, it improves the rates of pregnancy in women undergoing IVF. So reassuring data is emerging on the safety of anti-TNF agents in early pregnancy. It is often the practice now to encourage all women to continue on their anti-TNF therapy while attempting to conceive. For many, cessation of these drugs, particularly if there is a prolonged interval between drug cessation and successful conception, this delay could result in recurrent active disease, which in itself is a barrier to a pregnancy. So women with active disease in pregnancy, they have a higher risk of complications, including features of placental insufficiency, that is preeclampsia, fetal growth restriction, and small for gestation age babies. And then high chance of intrauterine demise also. Discussion of these risks and the high risk of preterm birth, both spontaneous and iatrogenic, and operative deliveries, they are often seen in women with connective tissue disease. The risk will need to be individualized to each woman's underlying disease, severity of the disease activity, and consequences of the disease. As part of the pre-pregnancy counseling, it is important to review all the women's other medications to ensure that she is on pregnancy-friendly drugs and that an appropriate plan is made for pain relief options and vitamin supplementation. Other consequences of chronic inflammatory conditions, such as the increased risk of venous thromboembolic disease, it should be assessed and plans made for the antenatal and postnatal management of this as required. So then they have given in this table, you will see that it is on accumulation of anti-tumor necrosis factor agents in the neonates. So if you are giving etanercept and it is considered safe, so it should be discontinued between 30 to 32 weeks of gestation. Infliximab, don't have to remember half-lives, they will never ask you. It should be stopped at 21 to 22 days, but I have seen another journal where they ask to stop at 16 weeks. So it can, if they give you 16 weeks, even that is a correct option. But better in all situations, you should stop by 21 to 22 weeks. Adalimumab, it should be stopped at 26 to 28 weeks. Certolizumab, it should be stopped at 28 to 32 weeks. So this one, certolizumab, if they ask you which is the safest drug, certolizumab and etanercept, these are the safest drugs. but this one is beneficial because it can be continued throughout pregnancy. Why it can be continued, we'll just talk about it. At present, the biggest concern of anti-TNF use in pregnancy relates to the transplacental transfer that occurs predominantly after, not before, after 20 weeks of gestation. So there are two factors that influence this phenomenon. First, the efficiency of the transplacental transfer, which is dependent on the molecular structure of the Fc portion of anti-TNF molecule and the half-life of the drug used. As anti-TNF agents, they are immunoglobulins. Transplacental transfer increases exponentially as the pregnancy progresses, with maximal active transplacental transfer occurring after 28 weeks of gestation. Likely, predominantly it will occur after 20 weeks, but the highest chance that it will be transferred through placenta after 28 weeks of gestation. Immunosuppression of the neonate is of major concern. Though small observation studies, they have not demonstrated an increased risk of infections. Infliximab, adalimumab, and golimumab, these are IgG1 monoclonal antibodies for the IgG1 subclass that are actively transported across the placenta from the late second trimester. Etanercept, usually it is used if the patient has rheumatoid arthritis. It has a shorter half-life with its modified Fc portion. It doesn't bind as effectively to the cytototoplast. Therefore, transplacental passage of etanercept to the neonate is less sufficient. Cord etanercept levels, they are much lower at only 3.6 to 7.4% of maternal drug use. How you will compare that to how much is going to the baby? By taking the drug level in the mother's serum and then amount of the substance in the cord blood. Then pegylated anti-TNF agent like sertolizumab. This is now being touted as the pregnancy-friendly anti-TNF agent. This is because its molecular structure prohibits active transplacental transport, and therefore it is reliant on slow diffusion across the placental barrier to reach the developing fetus. However, it has a half-life of 14 days, and the level detected in the cord blood varied from 1.5 to 24% of the maternal blood level, like less than 2 micrograms per ml. Then there are specific concerns about transplacental transfer to the neonate. Development of the neonatal immune system. Then it has been seen that in animal studies, the offspring of some macaw monkey exposed to golimumab at doses significantly higher than human treatment doses, it did not show any change in the lymphoid tissue of the thymus, spleen, and lymph nodes. So it is not going to suppress the immune system. Then what is the neonatal response to vaccinations? In a small observation study on neonates exposed to infliximab in the third trimester, none of the children had any immune deficits. At 6 months, these infants, they had normal immunoglobulin levels and appropriate response antibodies, antibody titers to tetanus and Haemophilus influenzae vaccinations. Therefore, all neonates, they should undergo routine vaccination with the exception of live vaccines like the rotavirus vaccine and BCG vaccine, even when exposed to anti-TNF agents after 22 weeks of gestation. So just remember, no rotavirus vaccine, no BCG. However, if the neonate is exposed beyond the recommended gestation, the PSR guidelines, they advise against immunization of the neonate for the first 7 months of life. The woman's etanercept can be resumed almost immediately after delivery if she has a wound from a cesarean section or perineal tear episodically, then withholding it for a few days while the wound heals, it would be advised to minimize the risk of infection. And we would encourage women to breastfeed on all biologic agents. These are the recommendations of this TOG article, authors of the TOG article. Then they said B cells depleting agents. They have different modes of action. So rituximab and belimumab, so like anti-TNF agents, B cell depleting agents are also immunoglobulins that cross the placenta from the second trimester onwards, resulting in transient cytopenias and neonatal B cell depletion that can persist for up to 6 months. So This is just the conclusion. So if you have no time to go over this full article, just go over this one. It is giving the same information. So the important point is that you don't have to give rotavirus and BCG vaccinations to the children if the mothers receive any biologics during last after 28 weeks of pregnancy. From 22nd week of gestation they receive. So don't give these live vaccinations like rotavirus and BCG to the children, because they can cause severe reaction. And in the same article they have mentioned that 2 deaths were reported when the babies were given rotavirus and BCG vaccination. So that is the only important thing. So you will get this article, so you should remember that which drug should be discontinued at which time. So for this one, this is the same article, that one we have revised. So they were asking you about infliximab. So 21 to 22 weeks, but write down that it can be discontinued even at 16 weeks of pregnancy also. So question number 9. Most teratogenic drug during pregnancy. So diazepam. So do you think that diazepam can cause any problem? So what type of drug is diazepam? Benzodiazepine. So it can cause cleft lip and palate. C is marijuana. This is cannabis indica. If your patient has taken this cannabis, because it is now available over the counter, so that you will do this urine toxicology screen, and it can be positive for this marijuana for 28 days. But both diazepam and this cannabis, they are not vasoactive, while amphetamines, which is a type of methylxanthine, it is vasoactive. Why? Because it has sympathomimetic activities, and the studies have shown that it is then you should know that amphetamine, it is not given as a separate drug. It is cooked with many substances, like they will make this crystal ice, met ice, so ecstasy. These are designer drugs. So many harmful substances are there, and we have not done any studies on them. So they are going to cause multiple congenital anomalies like cleft lip and palate, cardiac anomalies, fetal growth restriction deficits, and they contain many unregulated substances which we know nothing about. So B is the most teratogenic drug during pregnancy, that is amphetamine. Okay. Question number 10. Patient 2 centimeter with recurrent herpes. Okay, we talked about this one before, that if your patient has RCOG says that if your patient has recurrent herpes, allow her to go for vaginal delivery. But this is not the case if your patient has recurrent herpes. If there is active lesion which is active now in this patient, so you will have to offer her a cesarean section. The guidelines, they say that RCOG guidelines, they say that recurrent herpes, give her acyclovir suppressive therapy from 36 week of pregnancy, and let this patient deliver vaginally. But in practice, if the patient has active lesion, we are going to deliver her by cesarean section. So no SVD for this patient. She has to go for MSCS. The rest of the things are the same. I think in the previous sessions we discussed this, have HSV1 and 2. Okay. So let this woman go for cesarean delivery. And still you will have to run intrapartum. At the time of cesarean, you will run acyclovir. Question 11. 28 weeks with reduced fetal movements with normal Doppler and amniotic fluid index. So what is the management? So she is at 28 weeks, and Doppler studies are normal. So do you think that you need to do anything for them, for this patient? Because because they didn't tell us that this patient has some risk factors for PET. Yeah, yeah, yes, you have to go for that. And Yes, you have to run that. Yeah, yeah, that's true. Thank you very much for adding. Because many students they have this confusion because they are following this RCUG guideline, but the guidelines say, but in the island, all the protocols I have reviewed, they have the same recommendations that active lesion go for cesarean section. They can continue taking the acyclovir from 36 onwards because it will reduce the chance of vertical transmission. So, like if the patient has recurrent herpes, the chance of vertical transmission is just 2%, but still 2% can be 100% for some of them. So we have to give them therapy. And if she is contracting the primary infection during pregnancy, then 41% chance that baby can be affected. So that's why you have to minimize the chance of fetal exposure. So you are going to deliver by cesarean section, and you will tell them, the inform neonatologist, like you are doing in routine. So, and if the patient that we have a patient with who has been exposed to this herpes virus, so they should be present, and then they will see that the baby needs any treatment, antiviral therapy, or doesn't need that. Then second issue will be that for such patients, active lesions, just do the cesarean section. Then if the patient is adamant that no, she is refusing to go for a cesarean section, you will come across such patients. They will think that it is against their faith to have a cesarean section. So in that case also, just document the conversation and give them intrapartum acyclovir, but you can take certain precautions, because if the baby is there and you want to do fetal blood sampling, or you want to apply fetal scalp electrode, don't do that. Then if more than 4 hours have passed since the membranes were ruptured, then the risk for the fetus will increase. So you need to expedite delivery. All colleges agree on this thing, that we will have to augment labor. If she is in labor, augment it. If she is not in labor, induce her. So that's how you are going to decrease the risk for the baby. Okay. So reduce fetal movements. There are multiple causes. So what we have to do for this patient, if the patient comes to you with the first episode of reduced fetal movements, you will take a detailed history, what has happened, how many movements she has felt, and since when she is experiencing this reduced fetal movements. And then you have to review her for two things, that she doesn't have any risk factors for PET, and she doesn't have any risk factors for fetal growth restriction. And then you can reassure her, just they will check the fetal heart rate with handheld Doppler sonicate, and they will reassure this patient and ask her to go home and then lie down in left lateral position for 2 hours, and she should be able to feel like 20 movements. If she doesn't feel this number of movements, or the movements are very sluggish, then let her come back to the unit where she came in the first place, like in the primary center, or she came to the midwife led unit, or to the obstetric unit. Now during the second episode, as you all know, you will do offer ultrasound, and then you can do this CTG. If both are okay, reassure her, and then make a change in the antenatal care. Now it should be consultant led care, and give open appointment to this patient. If he has further episode of third episode of reduced fetal movement, then you have no way out. So you are going to give her, if she is preterm, like less than 34 weeks, give her corticosteroids and induce labor. And if she has any contraindication to normal labor, then you will give her plan a cesarean section on her as soon as you can do that. Not cat 1, cat 2, but you have to do that. Better if you can do cat 2 CSP, cat 3 CSP, because cat 3 also means you have to do within 12 hours. Why? Because the studies have shown that 24 hours before fetal demise, the woman can complain of reduced fetal movements. So then deliver her at any age. Okay, inform the neonatologist, give Maxal if appropriate, and give antenatal corticosteroids, and deliver through the most suitable route, and document in her notes. If I ask you about the causes of reduced fetal movements, what will you like to tell me? Anterior placenta, okay, neuromuscular disease, small for gestational age, maybe there is some fibroid, or maybe there is reduced liker. All of these are associated with less chance, reduced fetal movements. These are the points. So that's how you're going to manage a case of reduced fetal movements. Yeah, please. Hmm. Hmm. Yeah, you will. Yes, you will do assessment. If the bishop score is good, then you will, CS is always done because of obstetric indications. In cases of previous IUFT, the recommendations are like in your patient, she had an IUFT at 32 weeks. Ideally, you should deliver this baby at 31 weeks because the guidelines say that you have to deliver 1 week before the time of fetal demise in the previous pregnancy. We know that at this stage, high chance of failure of induction of labor, but for the sake of exam, you are going to induce her. Because on ground, what happens? If patient has one bad experience, she will never opt for induction of labor. She will demand a cesarean section, which will be justified also because she has suffered a loss and she will not like to go through the same unfortunate event again. Okay, so but for the sake of exam, you will offer induction of labor, elective delivery, which can be through induction of labor. If there is some contraindication to normal delivery or your patient declines that, then document in her notes and write down the reason also. Give her a little bit of counseling and after that go and do the cesarean section. So then you have to give full MIC, potpourri. Antenatal corticosteroids, Mexel can be given up to 32 weeks, then offer induction of labor and counsel her about the chance that if induction of labor fail, which is going to fail in like 30 to 70% even at term, and then deliver through cesarean section. That is the point. Okay. So anything else you want to add or ask? Yeah. Yeah. Please go ahead. Yeah. No complete question here. Reduce fetal movements. So you know, but CS will be done only because of obstetric indications. And no point in augmenting because the patient, as per the question, is not in labor. Okay. So plan elective delivery, or they will give you induction of labor. Why do people fail in the exam? Because the options are very vague. So you have to read them carefully and then apply the option which is most suitable for your patient. If they tell you that recurrent episodes of reduced fetal movement, so recurrent, they didn't tell you how many episodes have occurred, but this, but something serious is there. So before losing the fetus, you need to take action. So offer induction of labor. If that is not given and they have given you CS and then they are giving you the options of following this baby up, then go for the CS. Okay. So any other problem, any other issue? Okay, let's go to the next. Yeah, that is the point. So the other day I gave you people this homework that you have to go and revise anti-epileptic drugs because you are going to get at least 3 questions on them. So again, the next drug was the question was on some drugs, but you should remember that which drugs can cause neural tube defects: sodium valproate and carbamazepine. Then which drugs can cause orofacial cleft: phenytoin, phenobarbital, and carbamazepine. Then congenital heart defect: phenytoin, phenobarbital, sodium valproate. Valproate is the worst, V for villain and V for valproate, because it is going to cause major defects like both neural tube defects and also congenital heart defects. And congenital heart disease can be there. Sodium valproate, NTD, facial clefts, and hypospadias. This is written in the um, green top guideline. Okay. Then phenobarbital and phenytoin, they can cause cardiac malformations. Phenytoin and carbamazepine, they can cause cleft palate in fetus. So these are the drugs they have given here also. Actually, in all types, they don't expect you to tell them according to the etiology, because you can have different types of um, seizures. Like epilepsy, it is of many different types, but a few important points here, we'll go over them. So congenital anomalies associated with carbamazepine and sodium valproate, they will not give you ideal answer. Only if this sodium highest valproate highest chance of NTD, but when they are giving to both drugs, cardiac defect. So what do you think about epilepsy? How common it is? So the importance of epilepsy is that this is the most common neurological disease. Okay, if I will tell you about prevalence, it is 0.5 to 1%. This is the prevalence, that how many people with epilepsy they are present around us. Prevalence is 0.5 to 1%. And it is very important because in epileptic patient who is pregnant, the chance of death increases 10 folds. So that's why it is very important. So if your patient is like seizure free for 10 years, and out of these 10 years she was not taking any medicine for 5 years, so then what can happen, she can go off the drug, and then this is not at a very high risk. So then what type of seizures are more common? Um, some types of seizures, they are associated with high risk of sudden unexplained death in the epileptic patient, and out of them tonic clonic seizures, they are most notorious. You can see here also, if the patient has tonic clonic seizures, the old name was grand mal epilepsy, we don't use this. So here this is the associated with the highest risk of SUDEPs, sudden unknown unexpected death in the epileptic patient. So if they are taking drugs, then what is the chance? Overall, 2.8% risk of congenital anomalies, and if we are giving monotherapy, then two drugs, lamotrigine and carbamazepine monotherapy, like one of these drugs are being given, they carry the least risk of developing congenital anomalies. So if they ask you about the most common congenital anomalies with anti-epileptic drugs, they will give you full spectrum without giving the name. Then you should include neural tube defect, congenital heart disease, urinary tract abnormalities, skeletal abnormalities, and cleft palate. So if your patient is taking sodium valproate, this drug carries the highest risk of causing congenital anomalies, and according to this green top guideline, the risk of congenital anomalies is 10.7%. This is 10.7% with sodium valproate. And again, what anomalies? Neural tube defects, facial cleft, and then hypospadias. Phenobarbital and phenytoin, they are most commonly associated with cardiac malformations. Phenytoin and carbamazepine, they are associated with cleft palate. So highest risk of congenital anomalies, it will be like if your patient is taking polytherapy, and if there are in the normal population, the risk of congenital anomalies in the patient who don't have epilepsy, the chance of having congenital anomalies is 2 to 3 in 100, but this will increase multiple times when your patient is taking anti-epileptic drugs. And if the dose of lamotrigine is low, like less than 300 milligrams per day, it is given in divided doses, then the risk of having congenital anomalies is very low, like it will be 2 in 100. So, and similarly, if the dose of carbamazepine is less than 400, then again the chance of having congenital anomalies is 3.4%. If they ask you that which drug carries the least risk of causing any anomalies, then you should remember levetiracetam. This is the drug which. Hello, can you hear me? So levetiracetam, it carries the lowest risk of causing congenital anomalies, and the risk is 0.7%. So in polytherapy, the chance of having a baby with some congenital anomalies, it will increase to 5.6%. And if mother has one baby with any congenital anomalies after, because she was epileptic and she has some some baby with some congenital anomalies, then the chance of recurrence is 16.8%. So then the new studies have shown that if your patient is on sodium valproate, they will have low IQ also. Okay, and then it has been seen that high chance of autism if the baby in utero has been exposed to sodium valproate. So 2/3 of but the drugs, they have to be given, because otherwise your patient will have seizures and she can sustain traumas, so that's why you have to give them something. Then they can ask you about that, do you think that some patients, they will have no reduction in the seizures? Yes, sometimes if you will not give them these drugs, the frequency of having convulsions, it will increase, and sometimes your patient can become resistant to the effect of drugs also. Then they can ask you, they will give you a definition that what is status epilepticus. Then you should remember that it means that 30 minutes of continuous seizure activity, or like for 30 minutes she is having convulsions, or there is a cluster of seizures without recovery, like continuously she is having seizure activity and without any recovery. So then there is a problem that patients, like 15% of the patients, they will themselves discontinue the drugs, so the frequency of having convulsions, it will increase. Then when your patients are taking anti-epileptic drugs, you have to encourage them to register for the pregnancy registry. Then once you have seen the baby, then what should be done? We have to follow them for a detailed scan at 20 weeks for the detection of neural tube defects, because ultrasound is very useful and it can detect 94 to 100% of the neural tube defects. Then lamotrigine levels in pregnancy, they fall by up to 70%. Why? Because estrogen is going to increase the metabolism of lamotrigine. So you will have to increase the rates. And you will have to increase the dose of lamotrigine. So then sometimes they will ask you, what are the fetal risks besides congenital anomalies if the mother is taking anti-epileptic drugs? You should remember that the patient who is epileptic, despite taking therapy, she is still at an increased risk of having miscarriage, which will increase by 10 times. Then they are at risk of antepartum hemorrhage, PET, hypertension. Then they may need induction of labor and cesarean delivery, and then also increased chance of preterm labor, increased chance of fetal growth restriction, and then again increased chance of having PPH. So when they compare that about the chance of perinatal death and chance of development of GDM, then epileptics are not at an increased risk of perinatal death or increased chance of developing gestational diabetes, but other complications, they will increase. So, and the chance of cesarean section will increase if your patient is on polytherapy, like taking 2 or more drugs. So if the mother is taking anti-epileptic drugs, they can induce liver enzymes also. So there can be some liver dysfunction. So once she reaches 36 weeks of pregnancy, then you can start this vitamin K for the baby, or if it has not been given, then at birth make it a point to give intramuscular 1 milligram vitamin K to the baby to prevent hemorrhagic disease of the newborn. So because if your patient is on steroids due to some other cause, then again anti-epileptic drugs, they will induce the liver enzymes and they will increase the metabolism of corticosteroids. So if you need to give antenatal corticosteroids, you should take opinion of the physician that this dose is enough or we should give a higher dose. So then if your patient is like in labor, and you think that her chance of developing seizures is very high, then you should talk to the physician and you should give her long-acting benzodiazepine like clobazam. It has been observed extensively and less chance of having these seizures if your patient is on clobazam. So in labor, highest chance that patient can develop clonic seizures, like in 1 to 2% of the patients, and they can develop within 24 hours of the delivery. So higher chance in the postpartum period. So then you should remember that if your patient has received intrapartum clobazam, then high chance that there can be respiratory depression. So you need to tell the neonatologist that mother has received because this is a long-acting benzodiazepine. So how you will manage her labor? Continuous CTG should be done, and if there is increased chance of seizures or intrapartum seizures, so continue this CTG. So then at the same time, the chance of having status epilepticus, like patient will continue this having these seizures for 30 minutes or she will have a cluster of seizures, it is 1%. So if your patient is having status epilepticus, then what should be given? Start treatment with lorazepam. You don't have to remember the dose, but it can be given like 0.1 mg per kg body weight, and you will have to give IV. You give lorazepam and still your patient is convulsing, then you will have to give diazepam. How much? 5 to 10 milligram IV. So you can give stat IV in a like give it over a period of 5 minutes, or you can give it in the form of infusion. Still your patient is convulsing, then you can give diazepam. So if still seizure activity continues, then you will have to give midazolam 10 milligram. Okay, but you will call the anesthetist to give it to this patient. So still they are having this seizure activity, then you will have to give them phenytoin or phosphophenytoin. But usually they are interested in asking that patient has status asthmaticus, so what should be given to her now? Because anti-epileptic medicine she is receiving, but now increased neural activity, so we have to give them long-acting sedative hypnotic, and the benzodiazepines are the best drug for these patients. Sometimes due to this seizure activity, because this is a neurological activity, so you can understand that there can be hypertonicity of the uterus. So if you sense, and this uterus will be contracted and this will be very painful for the patient, so for this patient you will have to give tocolytic also. So what will you give her? Erythrobrain, beta sympathetic sympathomimetic activity. So if you need to give analgesia, then what type of drugs are safe for this patient? Like you can offer this transcutaneous electric nerve stimulation, because these devices are available. Then maybe you will have to give pethidine, and you will have to give regional analgesia, no pethidine, and you can give also Entonox. So if they ask you what type of analgesia you will give to an epileptic patient, your answer is give Entonox, which is nitrous oxide and oxygen mixture both in 50%. Then you can give regional analgesia like epidural, or then TENS if patient has some contraindication to these other forms of analgesia. So if you think that patient has some emergency, she is bleeding and it is essential to give general anesthesia, then the anesthetist will avoid giving pethidine, ketamine and sevoflurane, because they will lower the neurological threshold for convulsions. So that is the point. Okay. So if you have a patient whose drugs were increased during pregnancy, then within 10 days she should be reviewed, because she will develop toxicity, so her dosage should be reduced. So if they ask you that which drugs can be transported across placenta in high quantities, then you should remember lamotrigine and levetiracetam and topiramate. They can be transferred easily through the placenta. Then you should know that which drugs are excreted in the breast milk. So you should remember that carbamazepine and phenytoin, they are transported in, they are excreted in breast milk in lower extents. Then what can happen to the baby? There can be depression, like they can cause sedation. Then you should remember that incidence of depression in the epileptic pregnant women are much high. Like what is the incidence of depression in the women who have no risk factor? It is like on average 11%. But if she is epileptic and she is on treatment, then her chance of developing postpartum depression is very high. It is 29%. So you can see that it is very high, 29%. So your patient has delivered, she is fine. Within 10 days, her medications have been reviewed. She has been given advice on breastfeeding. Then the question arises that what type of contraception should be offered to her. So intrauterine copper device, this is ideal for her. Then if she doesn't need it, then you can give her, or she declines or she is not fit for that, like maybe she has some abnormality of the uterus, then you can offer her depomedroxyprogesterone acetate. You will take one precaution because DMPA usually it is given every 14 weeks, but in cases of epileptics you should repeat injection at 12 weeks to be on the safer side. If they give you one patient with epilepsy and she has come to you for emergency contraception, again offer her intrauterine copper device. So then you can also offer her, what else you can give her? Ulipristal should not be given because its level will also be affected by these anti-epileptic drugs. And then you should not give them COCPs also, because 3 times high chance of failure of this therapy. So if she is coming to you for emergency contraception, you will give her either intrauterine device or you will give her levonorgestrel trams, but as 3 milligram. You know, in the non-epileptic you are giving 1.5 milligrams. Now you will give her double dose like 3 milligrams, and it can be given within 120 hours and she is going to be fine. So if you have an epileptic and she says that she will like to have combined oral contraceptive pills because she is happy with them and she doesn't want to have IUCD or DMPA, then what you can do is that you can give her COCPs. These are not as such contraindicated, but try to give her that contraceptive pill which contains 50 microgram of ethinyl estradiol. Then it is safe. And then another precaution you can take is that usually when your patient is taking COCPs, I am talking about the older drugs, then you are giving them 7 days gap, drug holiday, then they will not take any COCPs. But in epileptics you can reduce this gap to 4 days. So 2 precautions: increase the dose of estrogen to 50 microgram, and you should remember that in routinely COCPs they will contain 20 microgram of estrogen. So increase that to 50 microgram. Then drug free interval, instead of 7 days give them 4 days interval. Then another intervention can be that you can tell them to continue taking 3 packs of COCPs back to back and then observe 7 days of pill free interval. So that's how you can provide contraception, effective contraception to these patients. So that's all you need to remember about epilepsy. So if I ask you which other COCPs they have a gap of like this drug free interval of 4 days, can you tell me about any drug? Qlera. Qlera is the 4th generation combined oral contraceptive pills. So your patient is going to take them for 24 days and then she will have a drug free interval of 4 days. That is the answer. Okay. So coming back to this table, you should remember tonic clonic seizures. Your patient has the highest risk of unexpected death. Then in cases of absence seizures, Here the patient will be lost for like 10 seconds and then she will come back, she will be responsive again. So if it becomes, it can worsen during pregnancy. So you are going to manage her pregnancy in with the help of neurophysician. Okay, so even if the drug has to be changed, it should be changed by the neurophysician. And you should remember that anytime she is having this loss of consciousness or they are sustaining a fall, then blood supply to the baby is compromised and baby will be hypoxic. That's why you have to um, offer them continuous electronic fetal monitoring during pregnancy. All this information is not required. Just remember the things that we have just discussed here. Okay. So do you have any question, any problem? But since this is the most common neurological disorder of pregnancy, so you should be 100% sure that they will ask you like 2 or 3 questions from here, mostly about their management, about the drugs and their side effects, at what time she is at the highest risk of developing seizures, what is status epilepticus, and what is the routine effective contraception for her, and how you will provide emergency contraception. Then if your patient is adamant that she needs COCPs, then how you can help her, how you can decrease the chance of failure. So we have just discussed these points and that's enough. Okay. Still any point which you think should be explained? Yeah, please go ahead. Yeah. Yeah, first question, you will give diazepam, okay? Whenever you have, actually there should have been lorazepam, because as we just read, these are universally accepted guidelines. Lorazepam should be given first, then diazepam. If and don't give rectal diazepam, that will be a wrong answer. You have to give intravenous diazepam. Still she is convulsing, give her second dose of diazepam. After that, still she is continuing to have this seizure activity, then you will call anesthetist. Why? Because now he should give her midazolam. And midazolam, this is just like pentothal. And this Michael Jackson also died because he was on this midazolam. Okay, remember it like that. So you need to call the doctor, call anesthetist. Okay, he will give midazolam because this is an anesthetic induction agent. So call him at that time. But the first and the second dose you can give that yourself. So that's how you are going to manage an epileptic. Then what was new in this guideline, that if the patient is having anti-epileptic drugs, then they can develop autism also. 2.9% is the chance. The baby can develop autism, okay? So just remember that point. That was a new thing. And rest of the things are the same, just like the previous guidelines, nothing new here. Any other question regarding epilepsy? And I have told you that here the induction of labor is likely to fail in them, and then high chance that they will have a cesarean section, and much higher chance if they are on multiple drugs. They are taking several anti-epileptic drugs at the same time, then they will have to undergo, then they will have this dysfunctional labor, so they will end up having a cesarean section. Then they can give you certain other questions. Patient was taking levetiracetam and she has become pregnant, so now she has come to you for termination of pregnancy. So then you are going to reassure her, because we have just read that this is the drug which carries the lowest risk of congenital anomalies, 0.7%. So don't give it to her, okay? So don't offer this termination of pregnancy, okay? Then they will tell you that patient had she was taking high dosage, and baby was found to be normal on congenital anomaly scan. So do you need to change the drug? So if her epilepsy is well controlled on the drugs she is taking, then you don't have to change that. The basic point is that you are not going to change her drug, you are not going to change her doses also. This is job of the neurophysician. and then in the preconception period you are going to give her 5 mg folic acid. This is not OTC, so you will have to give her a prescription. But this epilepsy during pregnancy is an important topic, and if you know the basics, you can help your patients tremendously, and of course you can get a better score in your exam also. So do you have any other question for me? Yeah, yeah, she will continue. Yeah, she will continue. We will tell her with lamotrigine and trigen and this one carbamazepine, lowest chance of transmission of this one. In negligible amounts, the drug will go to the babies, and it will only cause sedation, nothing else. So she can be continued on that. So do you have any? No problem at all. So I think we can have a break here if you like. Okay, so when are you coming back? After 15 minutes or 20 minutes? Okay, okay, because I want you to be fresh, take a cup of tea or whatever you want to do and come back. I'm staying online, okay? 20 minutes and see you again. Thank you, bye bye. Hello. Okay. Can you hear me? Hello. Yeah. Welcome, Sam. Yeah, I didn't realize that. Sorry, I'm a bit late, but I will give you this time. Okay. Question number 13. Patient with type 2 genital mutilation in early labor management. So de-infibulation can be done in first or second stage. So what do you think? Do we need to do something for type 1? Yeah. Type 1, type 2 do nothing. Yeah. So because yeah, so then they can do elective defibrillation at 20 weeks. This is recommended. Or if the patient didn't come to you like she is unbooked, then it can be done intrapartum also. So then related questions, because the in endosizer he said that defibrillation should be carried out, but the problem was that many people they question that should be done in type 1 type 2, so you don't have to do type 3, you have to do that one. Then another relevant question can be that if you have just seen someone with um, this female genital mutilation, so in UK you are required to inform the police within 4 weeks, but in the Irish system they are following the guidelines of the UK Genital guidelines, but still as such no recommendation that you have to report, but then you have to write down in her notes without anonymization. Just write clearly, and if she comes to you during the antenatal period and you have seen that mutilation is there, then uh, if the patient consents, then cover her and you can take a photograph and keep that in her notes. Otherwise they will give you a printed form, so just tick on that one, that what type of FGM she has, so that they will not examine her again and again. So what complications one can have if FGM has been done? Tell me about that. Mm-hmm. Mm-hmm. Okay. Yeah, penile tears can be there. Actually, whenever you are starting with the complications, you should start that what will be the complications in the early part. Infection can be there, bleeding can be there, okay, infusion cysts, they can be there, excessive bleeding, hemorrhage can be there. So patient will usually present with UTI, or they are unable to control the bleeding. So if they bring someone to you who has just undergone this procedure, then first you will take consent from her, then you will take this full history, write down details, examine in the presence of a chaperone, clean the area under aseptic conditions. Then of course you are going to give her analgesia and antibiotic, but you will have to give them anti-tetanus serum also, because usually these procedures are done illegally, so under unhygienic conditions you have to care for that patient. If she has urinary retention, catheterize her. Then in the postpartum period, the opinion on this obstructed labor is conflicted, because half the authors they say that this is not the case, that they will have normal labor, rather very fastly, they will progress very fast. But rest of the things like very difficult to examine, then very difficult to pass catheter, and sometimes the seal is so narrow that you will have to cut the whole area. You will have to give anterior defibrillation during labor to deliver, and still your patient is going to sustain tears. And then generally what are the problems faced by such patients? Anorgasmia, severe dyspareunia, then recurrent UTIs, because sometimes they will create this seal in the type 1, type 3, and patient is going to have many issues. Then they can develop psychological issues. Previous recommendations were that if patient comes to you and they are not happy with their appearance, then you can offer them reconstructive surgery, but this guideline was changed that you have to reassure them that it has nothing to do with their femininity and they are fine. And if they insist, then you have to send them for psychosexual counseling. Question number 14. 16-year-old. Yeah. Yeah, type 3, yes. Type 3 you will do. Type 1, type 1, type 2 do nothing. Just let her progress. And episiotomy you will do selective episiotomy, restrictive episiotomy only where it is indicated. Otherwise you don't have to touch the patient, okay? The same things. So if you have done your, yeah, yeah, do nothing, you will use this episiotomy selectively, okay? Because this patient will have a tight incoitus anyhow, because the healing is by fibrosis. So you can offer them, then you will do this episiotomy if clinically indicated. Then you should remember that for such patients the chance of cesarean section is higher, like 50% they will deliver by cesarean section. Then another question they will ask you, that you have just delivered a patient and she is requesting you to suture that tear, like you have done anterior defibrillation, and she is now asking you to repair anatomy. So you will refuse to do that, okay? That is the point. You will not entertain her. These are the practical points, okay? Yeah, only episiotomy during the second step. Okay, these are the options. No, but where is the option? This is the question. This is the question they have taken from Endometriosis. Here, first or second stage, no intervention. So in the second stage, what is the second stage? Second stage is full dilatation to delivery of the baby. So that's why they wrote no intervention. In the post-op period, she is asking you to suture her and you will decline to do that. Okay? And this question they have taken from Endometriosis, that there is a 22-year-old girl seen in the clinic at 12 weeks, history of FGM type 2, so what should be done? So defibrillation during first stage of labor, defibrillation during second stage of labor, elective CS at 38 weeks, elective defibrillation at 20 weeks, or episiotomy only for second stage. Actually this question is debatable in type 1 and 2 if you are not going to do anything, because in type 1 only they have removed the clitoris, so nothing further. So basically if there is type 3 then you have to do any intervention, otherwise you don't have to do anything. They are giving a reference of Endometriosis, so every time we have debate on this one, but the guidelines they don't say that if one or two then you should go for it. Okay? Type 3 you will do that one and refuse to suture again because this is not recommended. Okay? Question 14, 16 years old. So are you happy with that question? Because we will do nothing for her. Just observation and episiotomy as indicated. Because in type 3 the problem is that extensive area has been removed and sutured, so it is really very narrow, and sometimes the urethra will be just lying immediately this scar, so that is also a problem. So better you should do anterior defibrillation, because you have to avoid that damage to the urethra also. And sometimes there will be so many adhesions with allied formation that you cannot do the procedure. In that case, you have to decide about the mode of delivery at 36 weeks, because otherwise you can damage the underlying urethra also. This is the point. Okay. So, any other question, any issues you have here? But you will get like one question on FGM also. In each exam, they are including such questions. So, refuse to suture. Yeah, it will be vaginal. They can deliver easily, no problem with that. Type 4 as such is not going to be a concern because it includes burning, cauterizing, piercing, that type of thing. Type 3, the patient is going to have some difficulties because of the very tight seal is there, and it is hard even to examine. And your patient should not have pain. Anytime your patient has experienced pain, it will go against you. She should not have pain, and during childbirth they will have significant pain, so give local anesthesia and then cut this tissue. And this tissue will not bleed because all of this is fibrous tissue, so uh, no blood supply will be there or minimal bleeding will be there. So just cut them and you don't have to do that. So Then sometimes they say that if the patient has bleeding from that area, then you are going to cover the both sides of the scar with sutures, like you are securing the edges, okay, but you will not resuture. So if the edges are raw and you don't close them with suture, then they will re-anastomose, they will join with each other, okay. So it should not be done. So in that case, don't stitch the edges together, keep them on the separate sides, but just in a running way you will just run the sutures, okay. That is the point, on the sides of the edge, sides of the cut you have given, and then leave her as such. And antibiotics and analgesics as you will give to any other patient. That is the point. Okay. So can we go to next question? Or you have any concern, any problem? Question number 14. 16-year-old asking for contraception to give or ask parents. So you have to see that she has Fraser competency, that she is able to understand the information, then she can think over that information, and then she can decide, and then she can tell you that what she wants, and then you have to evaluate that you give her contraception or not. She is very likely to continue having this intersexual intercourse, and she is going to be harmed if you will not give her contraception. So you are going to give it to her. Which principle is applied here? Fraser's competence, and the patient is wise, she has mental capacity, and she is able to understand, then you will give her the contraception. Just you have your another part of this one is that you have to rule out any type of abuse, that she is doing it on her own, and she is not taking pressure from anyone, not taking orders from anyone. So if you will go to the RCOG strategy, they say that Gillick competency and Fraser guideline competency, they are the same things, the same name. So Lord Fraser is the one who passed that ruling, and this Gillick was the woman who complained against that doctor who gave contraception to her daughter, like that. So on social media you will find many things that Fraser competence, this is about providing contraception, and Gillick is about termination of pregnancy. No such thing, same thing. Okay, question number 15. CS cervix confined to cervix 4 centimeter management. So what should be done? Like if patient wants trachelectomy, so you know this is also a point of concern, because if you will go to the cervical cancer classifications, the staging, it says that up to stage 1B1, which means size of the tumor is less than 4 centimeter. Okay, it is not 4 centimeter or more, less than 4 centimeter. Even 3 centimeter you can offer this trachelectomy. But then in the detail they are writing even in the strategy that if the size of the lesion is more than 2 centimeter, refuse to do trachelectomy. But remember, any lesion less than 4 centimeter, you can offer trachelectomy. So what do we do in cases of trachelectomy? Any idea? Cervix and upper part of vagina. Upper part of vagina, paravaginal tissue, you are going to remove all of that thing. So then your patient can continue. But if your patient has a lesion which is greater than 4 centimeter, so what you will do? Yeah, yeah, lymphadenectomy will be done. So that is the point. So then you will not offer her trachelectomy, because you are unnecessarily endangering life of your patient. Okay, that is the point. Then question number 16. Radiotherapy. Yeah. Radiotherapy can be offered as a primary treatment, and that will be a good option for those patients like if they have fertility aspirations. But even for that, they said that it should be less than 1, it should be 1B1 or less. Anything beyond 1B1, there is no role of uh, conservative management or fertility sparing treatment. Okay. So that's why you will not offer. Actually, many people will be doing research on this issue also, that when you can offer primary radiotherapy, so then you can allow the patient. But the problem is that if the tumor is in stage 3 or stage 4, it is going to progress quickly. That's why the survival rates, they will be reducing. Like in stage 3, what is the survival rate? I think 22%. Stage 4 survival rate is just 10 or 13%. So then many other issues, they will come into play, that is it safe for her to continue a pregnancy, because we don't want to delay her treatment also, because you don't have to endanger her life. That is the point. We have to follow the guidelines. Yes, you will do radical hysterectomy for that one. Anything because if your patient is still in stage 1, the chance of nodal involvement is less than 1%. Stage 2, it is 10 to 15%. So say stage 2, you will have to do hysterectomy, and your radical hysterectomy, plus you will have to remove the lymph nodes also. That is the point. So then since you have to answer in the light of guidelines, that is the problem. Okay. So 1B1 or less than 4 centimeter, offer trachelectomy. Beyond that one, no. Decline to do anything else. No place for fertility sparing treatment. So you are going to do the needful. Offer her full surgery and evaluation. Okay. But this question is their favorite one, because the problem is that people are delaying this childbirth, and then these cancers, the cervical cancer also has bimodal distribution, and the incidence for even vulval is rising in those who are under 40. So we have to do the best for the patient, but then you have to maintain a balance between the risks and the benefits. Actually, all medical care, it swings between these 2 points. What is the benefit? What are the risks? These points. Okay, so you have to think about that. Okay, dears. Yes, dear. Yeah, still you have to. No, no, 1v1. There you have to stop. You will not go beyond that. At yeah, yeah, less than 4 centimeter, you can offer trachelectomy. 4 centimeter or 4.1 centimeter, refuse trachelectomy and give her radical hysterectomy or simple hysterectomy. Radical hysterectomy is done in such cases. Okay, no place for this simple one. Radical means that you are removing the uterus and you are removing the tissue around the from the pelvis also, from the and the paravaginal tissue also. This is going out. Okay? That is the point. So is it clear? Any confusion? Any second opinion? Okay. Yeah, no problem. Confined to cervix 4 centimeter. Refuse. Less than 4 centimeter, offer trachelectomy. 4 centimeter, no, nothing. Less than 4, offer it. 4 centimeter or more than 4 centimeter, no. You will not offer her anything, okay? Then you will offer her the treatment, no place for trachelectomy. Okay. So next area also, this is some concepts are very clear about on this perinatal mental health for women with mental issue, with these mental health issues. So postpartum and with hallucinations. So what should be done? So hallucinations, whenever they tell you about hallucinations, they can be visual, they can be auditory. The patient is hearing voices or patient is seeing something. So in that case, you will not assume that she has postpartum psychosis. You will take a history. What is happening? Is there any history before something? And so you need to evaluate her. But if it is a documented case, then you will have to refer to the psychiatrist. So if they will talk about the postpartum issues with the perinatal mental health, remember baby blues, the most likely time, most of the cases they will occur between 1 to 3 days. and 80% of women, they are going to feel low because of the sudden withdrawal of the hormones. And females, they will have concerns that they can't care for the baby, or they will feel low without any reason, or they will think that they cannot care for the baby. So these are benign. Just talk to the patient, reassure that she has a good support system at home and she is going to be fine. Incidence of postpartum psychosis is almost 1 in 3, like 33%. But if your patient has family history of psychosis, then her chance of developing psychosis is 50%. If she has a history of postpartum psychosis before, again her chance is going to be 50%. Then if your patient has history of bipolar disorders, in bipolar disorders, either your patient will have hypomania when she is feeling very low, or patient is having this at one end of the spectrum, patient will be maniac. She will be in a very good mood, shopping sprees, she will be spending lots and lots of money, socializing, going to the concerts, she is very happy. On the other end of the spectrum, she will go into severe depression, she will feel very low, she will have suicidal ideation, and she may harm herself also. So these are two spectrums, okay? So if your patient has history of bipolar disorder, then again her chance of developing postpartum psychosis is 50% in all of these conditions, okay? So most cases they will be seen between 1 to 3 weeks postpartum, and here patient will have a low mood, and patient can have hallucinations, and patient will think about harming herself or harming the baby. So if you get a patient like this, if something has been documented and she was being seen by the psychologist during pregnancy, perinatal mental health specialist, this is the subcategory, so that's fine, it is documented, so you can refer her back to the same person. Not documented, then you cannot send any patient, then you need to take a history, because for the depression of psychosis, as you know, you are going to use separate scores, standardized scores. If your patient has depression, then again there can be 10 or 11 different symptoms, and 7 should be positive for the diagnosis of depression. So you need to take a detailed history, establish the facts, because they have not been given to you in the question, and after that you can make appropriate referral. Now the third condition can be this one, postpartum depression. On average in general population, the incidence is 11%. Incidence is rising, and if the patient has history of psychiatric illness, then the chance of developing depression is 8 to 15%. Just now we read that epileptics, they have a chance of 29% that they will develop postpartum depression. So patient will have, how your patient will will present sleep disorder, so then suicidal ideation, insomnia. Patient will feel guilty about the situation that she has given birth to a baby and she is creating problems for others. Loss of concentration. Then patient will feel inadequate to care for the baby. Then she cannot eat properly and she is losing weight. Then she can have psychomotor agitation, can also be there. So, and then what else she can have? Loss of concentration, we said. She cannot do any work, she cannot sleep, she cannot eat, and she will try to kill herself, and then all of these problems are there. So you need to do proper evaluation for her. So it should be done in the psychiatric care, and they will give her different treatments. Then that's how you can identify different types of disorders, and then you will need to refer them to the perinatal mental health specialist for proper treatment. Mental health issues are very common, more common than we realize. They are very catastrophic, and relevant point that now 2 years ago, this maternal mortality report, it included suicide as the direct cause of death, and WHO also said that this is a direct cause of death, and like 25% of the deaths in the maternal mortality report, they were because of suicide, and patients used very severe extreme methods for committing suicides. Like most common was jumping from the roofs. That was the first thing. These are the things. So you need to screen them. That's why whenever patient is coming to you during antenatal care, you need to ask them, how has been your mood in the last 4 weeks? Second question, are you having as much fun as you were having like 4 weeks ago, or is there a change? So you need to ask them these questions, and if they say yes to any of the questions, you will refer them to the psychiatrist. These are the points. So don't be confused in the exam, and then you should remember that these time limits, like for the postpartum blues, 1 to 3 days, these are loosely applied because patient can develop such feelings even after 1 week. Some patients, they will develop these feelings after 5 to 7 days, but they are telling you 1 to 3 days most common to see the patient during this time. So patient has come to you, you are suspecting postpartum psychosis, then don't leave that patient alone. Admit her to the special care baby unit. But before reaching any conclusion, you need to take a detailed history. So anyone who is having hallucinations, you will not just refer her to the psychiatrist, you need to evaluate her. Then in medicine, we don't have to assume anything. If she is having any problem, just take a detailed history and then let her go to the perinatal mental health specialist. If your patient is safe taking some drugs, yeah, yeah, no, please go on. Yeah, she has hallucinations, but who else can have hallucinations? Maybe she took some drugs. People, they will develop hallucinations even after this Primpiran injection. Have you ever noticed? If you will give them Primpiran, patients will have extrapyramidal effects, and they can also have hallucinations. Those taking analgesia, anesthetic agents during labor, they can have them hallucinations. Those doing drugs or experiencing drug withdrawal, they can experience hallucinations. Okay, so you need to take a history that they have not taken any substance, and do they have any past history. Then what exactly are they feeling? Hallucinations, that if they have something thoughts like this, that they are going to harm their baby or they are going to harm themselves, this is an indication for keeping them inside hospital. So first of all, you need to take a brief history, and after that, of course, you are going to refer them. Because like I said, maybe she took only Primpiran and she is having hallucinations. So everyone who is hallucinating is not going to have this postpartum psychosis. And these problems of, yeah, yeah, please go ahead. Yeah, refer to the psychiatrist, okay? Straight away. Refer her to that patient, to that person. You don't have any exact history, nothing documented, take a detailed history. So if this is the only information, postpartum with hallucination, so you should take a history. That is the point. Okay. So question number 17. 31-year Montessori school teacher at 31 weeks with rash starting on abdomen involving the umbilicus and now spreading to limbs and patch coalescing, and saw 2 vesicles as well. So face is spared. So this one is involving the umbilicus. So if your patient has polymorphic eruptions of pregnancy, then your clue is that umbilicus is spared, nothing is there. But if it is not given and they are telling you that the umbilicus is involved, so she is having pemphigoid. So if we go over different types of rashes, these are very important because you are going to get questions from here also. If your patient has intrahepatic cholestasis of pregnancy, obstetric cholestasis, so what areas are affected? Yeah, palms and soles are involved, okay, and scalp, anus, vulva, abdominal skin, they are involved. Don't have to remember the incidences. All of them, they can have recurrence. So what is the most effective drug? Ursodeoxycholic acid. So then topical emollients, then sedative antihistamines, and then water-soluble vitamin K from the 10th week of gestation, because baby is also at an increased risk of developing hemolytic disease of the newborn. So here certain gray areas, that is it associated with increased risk of stillbirth? It has been observed, but still we don't have any concrete medical evidence. Increased risk of PPH, yes, because the patient can have abnormal liver function tests. They can have this PPH. Maybe clotting factors are not available in the system in adequate quantities, so they are going to have PPH. Fetal distress, we have no evidence. Increased risk of preterm birth, premature birth, it has been noticed, but still no concrete evidence. But it has been seen that this premature birth, this is iatrogenic as a result of some intervention. And then it is associated with meconium passage, and it has been observed that they will have a dysfunctional liver. So just observation that cesarean rate is higher if your patient has obstetric cholestasis. Then your patient can have ectopic eruptions of pregnancies. These are not very common. Here, you have to remember them by the differentiating points, that which areas are involved. So obstetric cholestasis, your patient will have involvement of palms and soles. Ectopic eruption of pregnancy, it can occur anywhere, but mostly it will involve the face, neck, and chest, extensor surfaces of the limbs and trunk. And patient will have family history of atopy. Atopy means that immunity is low. So again, what is the treatment? Emollients, so that she will not have itching. Then topical antipruritics can be given, topical steroids, antihistamine, ultraviolet rays therapy, and we can give topical acne treatment, because here patient will have very small, like pimples, very tiny ones, but she will be irritated and she will have itching also. Then polymorphic eruptions of pregnancy. It will involve abdominal stria and sparing across the umbilicus. So they will tell you that she has inflamed abdominal stria. So it can progress to trunk and extremities, and it will spare. So if it is sparing palms, soles, and face, think about polymorphic eruptions of pregnancy. Again, the treatment, topical steroids, emollients, and you will have to give antihistamines and give oral steroids. Why steroids are given in all conditions except this, this obstetric cholestasis? Because it is thought that all of these conditions, they have some autoimmune component. Okay. The next type of eruptions, pemphigoid gestationis. So they will appear around umbilicus, unlike polymorphic eruptions of pregnancy, and they can progress to trunk, extremities, palms, and soles with mucosal sparing. But these are bullous disorders. Your patient will develop some big eruptions, and it is associated with HLA-DR3 and 4. They will not ask you, they will just ask you that this is, sometimes they will not even give you the name, and they will just tell you that bullae are formed on the surface. Then you should know that two types of eruptions can be there, like bullous pemphigoid and pemphigoid gestationis. Okay, so if I ask you that which one is better, that this bullous pemphigoid or pemphigoid gestationis, you should remember that this is the worst form of rash a woman can have. Then they will ask you that what will happen in this disease. Sometimes they will tell you that where the patient is having deposition of these autoimmune complexes. So in pemphigoid gestationis, they are antigen antibody complexes or immune complexes. They are deposited between the cell lines, okay, between the cells. So what will happen? Cells will be disrupted. You will just touch the bulla and bullae, and they will just break down. Okay. So what is the treatment? Topical and oral corticosteroids, because this is a very bad condition, carries a poor prognosis. So you need to give topical as well as oral steroids, give antihistamines, and since the skin is breaking down, so they are more likely to develop secondary skin infections. So you will have to give antibiotics also. Then if the disease is well advanced, patient is not responding to anything, then you have to do immunophoresis, where they will remove the circulating immune complexes, and these patients, they will need immunosuppressive therapy. They will be given serums, and they will give them many other biologics, many other treatments are given. So self-limiting skin lesions in the neonate, but in the female they can cause IUGR and they can cause preterm labor also. So then what is the difference between pemphigoid gestationis and bullous pemphigoid? In bullous pemphigoid, the immune complexes, they are deposited at the junction of dermis and epidermis in bullous pemphigoid. But here they are depositing between the cells. This is the difference, okay? So we talked about obstetric cholestasis, that how frequently we should do the test, every 2 weeks, and then postpartum, when we are going to do the tests after 6 weeks. At 6 weeks appointment, you are going to do the test, and you are going to offer postnatal review. So what is the risk of recurrence of obstetric cholestasis? 45 to 95%, okay, very high risk of recurrence. So you need to counsel the patient that she should come to the obstetric clinic for antenatal care. And then important concept, that you should not give them estrogen containing contraception, because they will if their liver condition is not good, so it should not be given to them. Mode of delivery will be normal delivery of CS only because of obstetric indications. Mother has to take 10 mg vitamin K from 36 weeks of pregnancy. Baby should be given 1 milligram vitamin K at the time of birth. So then what else should be there? You need to inform the neonatologist to attend delivery. Patient can have PPH, that is the highest risk in such patients. So you have to do active management of third stage of labor. Then you should remember that obstetric cholestasis, this is a diagnosis of exclusion. When you have excluded Epstein-Barr virus infection, hepatitis A, B and C infection, and no CMV, nothing, then you will think about, and no other metabolic disorder, then no other skin disorder, then you will think about obstetric cholestasis. Okay. Question 18. 56 years old, unable to tolerate oral HRT due to migraine, but having atrophy and vaginal dryness, and problem is with the sexual activity. So what should be given to her? So we can offer her estrogen cream. Why? Because very little amount, they contain very low amount of estrogen, which is not going to exacerbate her migraine, not increasing her chance of developing cancers or anything, not increasing her chance of developing VTE. So we can offer estrogen cream. Even if she is a survivor of breast cancer, then you should remember you can offer her estrogen cream. But you need to tell the patient that she is going to have benefit as long as she is using it, and once she will stop using the cream, she will go back to her original status, because the treatment is not permanent. Okay. Question number 19. So question number 19 is that 36-year-old para 3, heavy menstrual bleeding and family is complete, so what should be done next? So her age is 36. If you will offer her hysterectomy at this time, then she is going to experience surgical menopause, so that's not an option. And otherwise also the first line management is to insert Mirena. So insert it for her, because this is an effective contraception and it is going to relieve her problems also. You don't have to give her anything else. Question number 20. 65-year-old, total abdominal hysterectomy was done 20 years ago due to fibroids, and she is sexually active. So she is post hysterectomy ward prolapse, they have written. Okay. So previous 3 cesarean sections, maybe previous 3 laparotomy. Oh, okay, maybe laparotomy. Previous 3, I understand that she had previous 3 cesarean sections and then laparotomy was done due to benign ovarian cyst. She is diabetic and hypertensive, so what is the next best surgical option? So remember that whenever they are giving you different options, they are giving you for a reason. So diabetic hypertensive may be unfit for anesthesia. So you need proper evaluation of her condition, and then this patient is sexually active. So sexually active, so you cannot offer her sacrospinous fixation, and you cannot offer her laparoscopic sacrocarpopexy. Why? Because she's going to have multiple adhesions because she had several surgeries on the abdomen. So offer her abdominal sacrocarpopexy. This should be offered. So C is the correct answer here. Question number. So if she is not sexually active, then what you will do? Here they are telling you she is sexually active, but if she is not sexually active, then you can offer her sacrospinous fixation. That is the point. Any confusion, any problem? I think we did this genital prolapse and post-hysterectomy wall prolapse. We have done at least 2 times. So you should have a clear concept that how to choose a proper procedure. Okay. Question number 21. 84 years old, ward prolapse, multiple problems. So what is next? So 84-year-old, you can safely offer her carpoclesis. What is carpoclesis? There are 2 ways of doing it. You are closing the vagina. You can do it in two ways. First one is that you can do this Lee-Ford procedure where you are using non-reabsorbable sutures and you are creating a small bridge between the anterior and posterior vaginal wall so that patient will not have any uterine or genital prolapse. The second way is that you will strip this epithelial lining and then you will spread some substances like talcum powder. These are irritating substances so that they will have itching, they will release chemical mediators of inflammation, and then healing will take place. So anterior and posterior vaginal walls, they will be close to each other, so they will heal, and then there will be multiple adhesions, so this area will be closed. So this procedure can be offered in the older women. If you will do it in the younger patients, then you can have multiple problems. Like when we were doing this cervical screening program, we talk about it that if such patients, you have done carpoclesis in the younger patient, then you cannot approach her cervix. So if she is developing any cancer or she is developing any infections, then we can't help her much. So we will have to use the abdominal route. So that's why in the older patient you will offer carpoclesis, but in the younger ones you are going to offer different treatment options. Start with lifestyle modification and pelvic floor muscle training. That's not working, go for the physical methods like we will offer the pessaries. If they are not helpful, then you will have to go for surgery. What type of surgery should be done? It depends upon the fitness of the patient and the expertise of the surgeon also. And then what is the history of patient? So then you are going to choose the appropriate procedure. You should know about the benefits and drawbacks of all procedures. So which one is associated with higher blood loss? Um, Abdominal sacrocolpopexy or vaginal sacrospinous fixation? Yes, sacrospinous fixation. And then which one is going to take longer? Abdominal procedure or the vaginal procedure? So who is going to stay longer in the hospital? Sacro Abdominal sacrocolpopexy or sacrospinous? Sacro Sacrospinous people, they are going to stay in the hospital for a longer period. Why? Because they are very likely to develop urinary complications, more chance of UTI, higher chance of wound hematoma. So they will be staying in the hospital for a longer period. So which one is associated with higher reoperation rate? Abdominal sacrocolpopexy or sacrospinous fixation? Sacrospinous fixation. Sacrospinous fixation. And during this sacrospinous fixation, you can damage her ureter and you can damage internal pudendal artery. And then if you will damage her, which nerve, that is also a question, that which nerve can be damaged during sacrospinous fixation. Which nerve can be damaged? Yes, obturator can be damaged. So what can happen to this patient? Right buttock, that will be affected, and then she can have right buttock pain, but it will go after some time. Within 3 months, it will resolve. So they will give you a patient who has undergone this procedure and she is having pain in the buttocks, and they will ask you how to manage her. Just give simple analgesia and no need to do any physiotherapy or anything, because it will go away within 3 months. Question number, yeah. You know, if the patient, this patient is very old and they're telling you multiple problems. So if she has multiple problems, then she is already 84 and the tissue will not heal as you will expect. So yeah, so nothing, just offer this one. Yeah. Yeah. Okay. Actually, you know, for me, her voice is cracking for me, so I couldn't hear her properly. So please, if you have heard, then please tell me about the question. Yeah, what is it? Please, can you please repeat your question? Okay. 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 So you should know that for uterine prolapse also you can do this procedure. But if this is not given as an option, then you will have to do the abdominal sacrocolpopexy. Okay, patient is unfit for the surgery, then you will give her the option of this pelvic floor muscle training. If not working for her, you will give her physical method, give her a pessary. If she can't tolerate that or declines, then you have no option. Then in a higher center, you will have to go for surgery and do it. If she can't tolerate this open procedure, like it will take some time and she has comorbidities, then you can do it laparoscopically also. But it should be done in expert hands, because otherwise it is going to take longer time. Because you know, if whenever your patient is symptomatic, you have to do something for her. So your challenge is that choose the suitable place and suitable procedure and how to counsel your patient. Okay. Then most important, you have to respect wishes of the woman. You are not going to impose your own decision. That is important. So that, does it answer your question, or still there is some confusion, some problem? That's okay, no problem. So question 22, 80 years old with ulcerated coccydentia, what next? Option A, give antibiotics. B, vaginal packing with clindamycin. C, packing with clindamycin plus urethral catheter. So C is the best option. If whenever you are packing the vagina in such patients, you need to insert Foley's catheter also, because it can cause obstruction of the urethra and patient may be unable to pass urine. So C is the correct answer here. So regarding antibiotics, you can pack vagina with any type of antibiotics, but you have to see that what is the age of the patient. If the patient is like 80 years old, if and you have given her clindamycin and she is not responding to treatment, like there is no healing, or even in a younger patient, like she is in not young, but as compared to the 80s, she will be younger, like she is in her 50s or 60s, and she has an ulcer with uterine prolapse, because prosidentia means complete prolapse of the uterus. Okay, so if she has an ulcer and you are continuously giving her antibiotics and she is not improving, then what should be your next action? Give local estrogen cream. Why she is not healing? Because the epithelium is deficient. So epithelium is deficient, it is not going to heal. So in that case, stop antibiotic treatment, give her Premature cream or local estrogen cream. Once the healing is it starts, then you can start back this antibiotic therapy. And whenever you are going to pack her, you will have to pack her, because if you will not pack, then whole of the uterus will come and lie outside in arthritis. So that's why. And in this scenario, when she has an ulcer, you cannot insert pessary also. That is the problem. Okay, so you will have to give her something. Give antibiotic, no benefit. Give Premarin cream, pack with vaginal packing, and insert urethral catheter. Similarly, if you for the duration of therapy, I have seen that sometimes you will have to keep it for 5 days also, because if you are taking all precautions, the healing will start within 72 hours. It is starting from 24 hours, but you are going to see clinical improvement within 72 hours. So you cannot keep this catheter like for 7 days or for 14 days, but for 3-4 days that is acceptable. That is the point. Remember that when we were talking about this voiding dysfunction also, we said that we can, if the patient is having postpartum voiding problem or post-surgical voiding problem, then you can keep this catheter, like you have done all initial workup. Then after that you have realized that patient actually has some voiding problem, then you are going to catheterize her for 2 to 6 weeks. So 2 weeks in certain scenarios, but here in this case 3 to 5 days is going to be sufficient. And then it is different, because it depends upon your consultant also. Some of the consultants, they will tell you that no, keep it only for 3 days and then remove the catheter. So that's why they will not ask you such questions. But if your patient has voiding issues, then they are definitely going to ask you that for how long you are going to keep that. So if you are inserting catheter for 2 to 6 weeks, then again you will have to choose that you are using this simple Foley's catheter, or if you are going to introduce suprapubic catheter. So most likely this will be done by the urologist, and he will insert suprapubic catheter. That is the point. But your job ends here. Once you have chosen the right treatment, then you will arrange that the urologist will come and do that for you. But you have to reach some conclusion. Okay. Question 23. 21 years old, light periods, postmenopausal symptoms. What next? So it can happen, especially if your patient has Turner mosaic. I'm revising these conditions because whenever you think about a condition, all relevant information should come to your mind, and then you should as you are reading the question. Okay. So and then patients can have premature ovarian insufficiency also, idiopathic most common, then in association with autoimmune disorders, then in association with metabolic disorders, and then third one, if they have some infectious etiology. All of these things are going to cause premature menopause. So your patient is symptomatic, so she will need therapy. Then when we were doing this nice guideline on menopause, we said that for such patients who have premature ovarian insufficiency, you can give them combined hormonal therapy, or you can give them, what is the second option? You can offer them COCPs. So COCPs are better for such patients because their function will not cease immediately and it will not be 100%. Some of them, they can ovulate sporadically, because if maybe some follicle will undergo the stimulation and it can cause ovulation. So better that if you will give them combined oral contraceptive pills sequentially. But if it is not given in the options, then you will give her combined hormonal contraception for 6 months, or you can give them, this is the COCPs. Other option is to give them low dose HRT. If patient has some contraindication to COC, then you will give her low dose HRT. So CHC is a better option for her, and this is not for 6 months. You are going to give it to her till the age of natural menopause, because if you will not give it to her, now your patients. Yes dear. Yes please. Fertility, yeah, because if she is showing concern about fertility, you will send her to the fertility specialist, because he will see that does she have any ovarian reserve left. But now they're telling you, see, they are always giving you a clue in the question that what is the correct answer. So here they are telling you patient has postmenopausal symptoms. So even if we will refer her to the fertility specialist, he will not give her anything to control her postmenopausal symptoms. If you are her specialist, this is your job to address her primary concerns, treat her clinical condition, and then refer her to the appropriate specialty when required. If they tell you that patient has infrequent periods, she has vasomotor symptoms, and she is very keen to have a baby, in that case you have a point to refer her to the fertility specialist. So who should go to the fertility specialist? Both male and females, if they are taking some gonadotoxic therapy, which is the most gonadotoxic substance, cyclophosphamide. So uh, if they are teenagers, even if they are teenagers or they are in their 20s and they have unfortunately developed some cancer, some tumor, and you need to treat them with chemotherapy, in that case you will refer them to the fertility specialist to see them. Then if you cannot offer this fertility sparing treatment, or if your patient has like early stage cancers, like especially true for the ovarian cancer, that is the only cancer where you can remove the ovaries and you can place them in some other place, like under the spleen or under the rectus sheath, from where she will continue to produce eggs. So here you can refer them to the fertility specialist. But this one, she has ovarian insufficiency and she is exhibiting postmenopausal symptoms. So you need to treat them, because they're not asking you about her overall management. If they give you this option that start on combined hormonal contraception, refer to fertility specialist, that would be the ideal answer. But they will not give you both together, because they want to see you that how you address this issue. So the first important point is to treat her postmenopausal symptoms. So if she is in a better condition, only then she can decide about her fertility issues. Otherwise also you should remember that if the patient has premature ovarian insufficiency, then she is planning to have a baby, then how she can do that? Because her ovaries are not working, so you will have to give egg donation, arrange egg donation for her. Okay, that is the point. So here A is the correct answer. No problem at all. Okay. Okay. So question number 24. Okay, if you are sending your patient to fertility specialist for ovarian preservation, you have to tell them that all of the procedures are experimental. What they can do is that if they will find some area which contains eggs, maybe they will cryopreserve eggs. But and if the patient is undergoing some cancer therapy, then maybe they will take strips of the ovarian tissue and keep them, and then after completing the treatment they can re-implant. But you should remember that all of these procedures are done only in the clinical trials, because they are very expensive. Like if you want to preserve someone's eggs, they will be spending like £6,000 a year, which is a lot of money for them. So all of these things are done, but in clinical trials, not for the general public. Remember I told you that now they have developed certain treatments which can delay menopause for a decade, and the patient will have to bear the cost of therapy, which is again £6,000. This development occurred in the first week of August. Okay, it was approved that those who have some concerns, some issues, they have to pay a price, and then menopause can be delayed for a decade, for 10 years. Okay. Question 24, 30 years old patient. Yeah. here you are going to choose, and this will not be for 6 months. This is actually till the age of normal menopause, 51.8 years. Okay, please, so far someone's speaker is very close to you, so keep it away. Okay. Question number 24. 30 years old patient with 2 miscarriages. Husband is 46 years old. Previous pregnancy was 9 months back, ended by surgical termination. Since that time, she has light periods, mild hirsutism, and BMI is 20. So what is next? So this patient had surgical termination of pregnancy. So maybe she has developed endometrial adhesions or Asherman syndrome. So if they are trying to confuse you that she has mild hirsutism, so mild hirsutism can be there without having PCOS. BMI is 20, so even if the patient is of normal BMI, still she can develop PCOS. But here the PCOS is not the etiology. So this patient developed amenorrhea and the light periods after surgical termination. Metformin not required. Dye test and laparoscopic ovarian drilling, yes, it can be done. But what is the benefit if they are telling you that there was surgical termination? So what should be done? Surgical termination, if they give you this clear clue that condition started after surgical termination, then you need to do hysteroscopy and adhesiolysis at the same time. This is very effective treatment. This is cost effective and patient can bear the expenses, so this is easy to do. So you should do this procedure. So if it is not given there and they are telling you that patient has, does this patient have any problem with conception? No, she doesn't have, because she has conceived 3 times. 2 ended up in miscarriages and third one she went for top, and it was just 9 months back. So by any standards, she doesn't have this infertility by any standards. Okay. Dye test and laparoscopic ovarian drilling, where you will do that? If the patient comes to you for the treatment of infertility and she has history of having comorbidities. What comorbidities? Like she has history of having PID, history of having PID or endometriosis, or maybe some surgery was done. In that case, the ideal test to see tubal patency will be laparoscopic ovarian, will be mini lap and dye test. So if patient has no history of comorbidities, then you can do hysterosalpingography. Recently, RCOG said that hysterosalpingography is not a very helpful intervention. Why? Because 25% patients, they will have this impression on hysterosalpingography that they have a blocked tube. While when you will do this laparoscopy, then you will see that 25% patients diagnosed, like if you have 100 patients who underwent this hysterosalpingography and they were diagnosed to have blocked tubes, then you will see this finding will be confirmed in 71 to 75% of the cases. Other 25 patients, they will be false positive. Remember doing a quiz like this, a question in the quiz, that in how many patients this finding will be confirmed on laparoscopy? In 71 to 75%. Okay. So RCOG said that you should do this one, saline infusion and sonohysterography. That is better than doing hysterosalpingography, but unless the RCPI changes recommendation, we will stick to hysterosalpingography if patient has no history of PID, endometriosis or ectopic pregnancy. So clomiphene citrate, right now we don't have any indication for giving any treatment for fertility, and then your patient's problem is that she has very light periods. So now there are 2 ways of addressing this problem. If she has light periods, so maybe she has PCOS, because at BMI 20 also she can develop PCOS. So if they will give you the options, what investigation you will like to do? Because if your patient has Asherman syndrome, then do you think that she is going to have light periods? Light periods mean that, yeah, she can have light periods because there is no complete blockage. Yeah, so light periods mean that endometrial proliferation is very less. So there is deficiency of estrogen, okay? And you know that in PCOS also your patient can have low level of estriol, low estradiol, low level of estrogen, and low FSH and LH. So that's why how you should investigate this patient. No need for metformin, diet test or clomiphene. Actually you need to do ultrasound to see that how are her ovaries, okay? And if they don't give you the option of this ultrasound, then what you can do is, then keeping this thing in view, surgical termination, you will have to do hysteroscopy. If they are telling you in the question that her concern is only, because this question will not be like this, they will tell you that she is asking you a question, she is asking about her periods or she is asking about her fertility. If she is asking about her periods, so you have to see that first you will do the ultrasound. First of all, if a patient comes to you like this, you will need to do proper evaluation. Pregnancy test is negative, then you will see you need to do the, in the given scenario you need to do ultrasound to see that how are the ovaries. If no polycystic ovaries and patient has no history of weight loss, then you will have to do hysteroscopy to see, to break the adhesions. That is the point. Then I remember this question. Actually in this question they also said what should be done next, and the option A actually was lifestyle modification. So diet and exercise, this therapy, that is also helpful. What is your clue that she has PCOS, that she has developed mild hirsutism? These things may be coincidental. Previous to miscarriages, maybe they were spontaneous, but you know that if your patient has PCOS, the incidence of miscarriages is higher in patients with PCOS. Surgical termination, so if that there was blockade, then there should have been no periods at all. But mild hirsutism, BMI 20, so looks like a case of PCOS. You're not going to give her anything because they are not helpful. Metformin you will give if she's concerned about her her appearance, that she has facial hair. So the answer for this question was lifestyle modification or diet and exercise, because it has a role in the management of PCOS. Then you should know that PCOS cases, 1/3 they will have normal BMI. But the basic pathology in PCOS is that LH level will be high, and you know it is not fluctuating, while to cause ovulation there should be LH surge, and these patients they will not have LH surge, they have basal high level of luteinizing hormone. So insulin should enter the ovaries to decrease the level of LH, and in a thin patient the basic pathology will be that LH level is very high. So high LH level, this is going to cause an ovulation and going to cause insulin resistance also, because in ovaries the insulin will not enter in the resting stage, rather in all muscles in the body insulin can enter the exercising muscle. That is the logic, that in all such cases we are telling our patient to take a diet with low glycemic index, and then she should work out. She should do like brisk walking, and what is recommended, 90 to 120 minutes of moderate physical activity 5 to 6 times a week. That is the recommendation. So this patient should do diet and she should do this lifestyle modification. She should do exercise so that insulin will enter the ovaries and decrease the level of LH, and then restore her normal cycle. That is the point. So read the question carefully. Here in the three options we have no Asherman syndrome, and for me this is a case of mild PCOS. So she needs to do some exercise and then she's going to be fine. So read the options carefully. You know very well about the PCOS. Okay, question 25. Rh negative patient came for routine antenatal anti-D prophylaxis at 28 weeks. and antibody anti-D level is 1 international unit per liter. So how you will monitor her? So antibody level is not 0, 1 international unit per ml, that's how we describe. Okay, so even if it is per liter, so your patient has 7 liters of blood, and if you will calculate, she has 7 international units of anti-D, so you need to monitor them. So monthly monitoring of antibodies, that is the point. Okay, so rest of the options are not correct. So you will give monthly monitoring with monitoring the anti-D level. Yeah, month. No. This is not. This is fortnightly. Fortnightly. Because yeah, thank you. Because patient is at 28 weeks, right? Before 28 weeks, we are going to do monitoring every 4 weeks. But once she has reached this 28 weeks, then you are going to do fortnightly, like every 14 days, to monitor the level, because she has a low risk of developing hemolytic disease of the fetus and the newborn, but still the chance is not 0, so we need to screen that. And as you remember that many different types of anti-D antibodies atypical antibodies can be there, but we are concerned about anti-D, anti-C and anti-K antibodies. For anti-D level of 4, more than 4 but less than 15, between 4 to 15, less than 4, mild chance of developing fetal or neonatal anemia. 4 to 15, moderate chance. More than 15, like at 16, high risk of developing uh, disease. So whenever your patient has like level is more than 4, you are going to refer them to the fetal medicine specialist. For anti-C level, less chance of developing HDFN if the level is less than 7.5, moderate chance if the level is between 7.5 to 20, and high chance if it is more than 20 international units, like at 21 the risk will be very high. So again you need to refer her to the fetal medicine unit. And for anti-K, they are associated with very high risk, so the moment they become positive, you will need to refer your patient to the fetal medicine. So then every 4 weeks we are going to test the level of anti-D hormone, anti-D antibodies, and then at 28 weeks or later we are going to test the level every 2 weeks until delivery. So, and the problem with the anti-K is that they don't correlate with the development or severity of the fetal anemia, so that is the problem. So every 2 weeks you are going to monitor them. And what is the aim of this intervention? Because anytime the fetus develops anemia, then you will have to deliver the baby. Other option is you will have to do intrauterine transfusion. Problem with in utero transfusion is that it is associated with fetal loss rate of 5%. That is the risk. Okay, so if they give you a baby who is at like 30 weeks, 31 weeks, then the option is that give her in utero fetal blood transfusion. If it is more than 32 weeks, like the age of viability, then you will give antenatal cover and you will deliver them. That is the point. Okay. So next question, 80 kg woman needs thromboprophylaxis. So what is the correct dose? I told you people before that they have given a small table that is included in your summaries of the RCPI guidelines also. So you will give the dose according to the weight of the woman. She is 80 kg, so in the normal weight limit, because the normal weight limit is considered when the weight is between 50 to 90 kg. So this is the correct dose. Tinzaparin 4500 international units per day. So tinzaparin 175 international units you are going to give if your patient is like at more than 130 kgs, more than 170 kg, then you are going to give how much? 175 units per kg body weight you will have to calculate. So this, then you are going to get one question from here, so it is worth reading. Okay, just remember the doses. 27, patient at 12 weeks, no family history of VTE but history of thrombophilia. She tests positive for heterozygous factor 5 Leiden mutation. What is next? So this factor 5 Leiden mutation, this is the most common type of thrombophilia acquired during pregnancy. So if your patient is homozygous for factor 5 Leiden mutation, then how you should manage her? 35 times higher risk that she will develop VTE. So she will need antenatal and postnatal therapy. So if your patient is factor 5, there is factor 5 Leiden mutation but of homozygous variety, then you will need to give her prophylaxis 6 weeks postpartum, but not in the antenatal period. Okay, so she has no family history. If she has a family history, if she has a personal history of developing VTE, then we will have to give her in the antenatal period and also in the postnatal period. But if she doesn't have a personal history, in that case we will have to give her postpartum prolonged thrombophilia thromboprophylaxis, not for 10 days. Okay, this 10-day prophylaxis is for everyone who has undergone this elective cesarean section or emergency cesarean section. But for this patient, you with the heterozygous factor 5 Leiden mutation, you are going to give prophylaxis for 6 weeks. I think we have done this question before also. So they will give you that option. Here just 3 options are given. Okay, question. Post normal delivery you will not give, but post surgical you will give for 6 weeks. Postpartum, if you will see, if she has 2 factors, then you will give for 10 days. Okay, if she has 2 factors, she has another additional factor, then you will give for, if she is positive for heterozygous thrombophilia, then you will have to give for 10 days. Okay, but if she ends up with a cesarean section, then you will give for 6 weeks. Yeah, that is the option if your patient has homozygous factor 5 Leiden mutation. This is the most commonly acquired thrombophilia during pregnancy. If she has a family personal history, then you will give her antenatally and postnatally. If no personal history, then you are going to give her 6 weeks post cesarean section and 10 days post an SPD. For postpartum thromboprophylaxis, actually you have to see that there should be 2 risk factors. Okay, then give for 10 days. Otherwise, it is not indicated. Question 28. 40 years old, diabetic and obese, BMI 40, and she has heavy menstrual bleeding. So what should be done? So this patient has all the risk factors for development of endometrial hyperplasia, and we are not going to assume anything. So if you will go to the new guideline, the recommendation is you should do hysteroscopy and endometrial biopsy. So for this patient, if you will do hysteroscopy without doing without taking endometrial biopsy, then this intervention is not helpful. So in this patient, what do you need to do for her? You need to take endometrial biopsy. If you will do only hysteroscopy, is it helpful? Hysteroscopy means you have to combine, actually, that if your patient has all the risk factors for endometrial hyperplasia, ideally they should give you this option, that do hysteroscopy and take endometrial biopsy. That is the complete answer. If they don't give you hysteroscopy, then no benefit of doing blind endometrial biopsy also. Actually, these should be combined. But if they don't give you this option, then then you are just doing the scopy. So doing the scopy is helpful. The complete answer is hysteroscopy and endometrial biopsy. So in the exam they should give you histoscopy and endometrial biopsy. That is the correct option, because I understand that we will do histoscopy and then in the next step we can do endometrial biopsy. But ideally both options should be in one line. If they don't give you together, then you know that your patient has all the risk factors for endometrial hyperplasia. That is the problem. So if you remember this, recall. So that was the only information given in the question, or there was some additional information? Any one of you, if you remember any question? Okay. If they ask you that what is the next, yeah, yeah, and yeah, that one. And we chose the answer that we should, maybe they ask that what is the first step. So it depends upon the question. If they ask you what is the next best step in the management, you will say histoscopy. And what you will do, but why you will do histoscopy? To take endometrial biopsy, because you need now no place for blind endometrial biopsy also. So in that case, if they are asking you about the next best step, you will choose histoscopy. And if they ask you that which investigation is most helpful, then what will you tell them? Biopsy, because by simply saying it is not going to help you. The rationale here is, okay, I will agree for this answer that we should do histoscopy. The reason is that this patient is obese, she is diabetic, she has plenty of estrogen in the system. So what can happen? That she can have polyps. These polyps, they may cause heavy menstrual bleeding, they can cause intermenstrual bleeding also. So maybe you will visualize the polyp. But actually we need to have histopathological diagnosis also. We need to have the endometrial biopsy. So first step, I would agree, do histoscopy, and if you find something abnormal, then you should take endometrial biopsy. But I hope that in the exam, out outpatient for all diagnostic procedures, you will do outpatient management. So please correct this option for 28. This is histoscopy because that is the next best step, but they will give you a combination histoscopy and biopsy or pipal biopsy. Then you should remember, and they will give you the information that patient A has some contraindication to anesthesia. Then you remember, for the diagnostic procedures you don't have to give any anesthesia. You can do it just by giving them NSAIDs like morphine, and they can take Voltaren, or if they are still feeling the pain, then you can offer them conscious sedation with the help of fentanyl and bupivacaine. So diagnostic procedure, take outpatient, do this outpatient histoscopy, because patient acceptance is better, they can tolerate it well. And if you have to do any therapeutic procedure, then you will take her to the OR. That is the point. So for this patient, do histoscopy. Oh, yeah, offices are located outside and the patient will go there, just like OPD. Patient will go there and then they will have like they have like this special histoscopy units. They will give analgesia to the patient 1 hour before the procedure. They will change their gown and then you are going to take it. So conscious sedation can be given. Second option is to give cervical block, and when you are giving cervical block, they can ask you what are you going to do. So you will take 20 ml of local anesthetic agent. You will avoid injecting at 3 o'clock and 9 o'clock position of the cervix, because that's where the cervical arteries are entering the cervix. So best option would be to inject at 2 o'clock, 10 o'clock, 4 o'clock or 8 o'clock positions. Two positions you are going to inject. You will hold the cervix with diaculum and then you will introduce the scope. Better results if you will use rigid scope. Outer sheath should be 3.5 millimeter. And then which distension medium you are going to use? Normal saline. Because with normal saline, less chance that there will be bottle intoxication. So then this is recommended as the distension medium. So rigid scope should be used. Whatever you are seeing, you should document, and that's how you can carry out the procedure. So then you have done this hysteroscopy, you have taken endometrial biopsy. If there is hyperplasia and the patient is obese, you are starting her on, you can give Mirena, or if that is not acceptable, then you are going to give her what? Then you will give her oral progestogens. Two progestogens have been licensed for this purpose: depomedroxyprogesterone acetate, 15 to 20 milligram daily in divided doses. Say you can give it BID for at least for 90 days without a gap. The second option is to give norethistyrone 5 to 10 milligrams BID for 90 days, and if the patient is benefiting, prolong it to 90 days. And then you prolong it to 180 days or 6 months. First line is Mirena insertion. So once you have inserted this device, or you have started them on progesterone, then after 6 months you are going to take a biopsy. So you need 2 samples, biopsy samples, before discharging the patient. So, and if your patient is obese, then what are the recommendations? I think we talked about this one also. Then how often, then are you going to discharge her after 2 negative histopath samples or what? Yeah, yes, annually follow up. Okay, then either if she decreases her BMI, then you can stop screening her, or if she doesn't develop any further complications, then you can leave her. But if she continues having, because you know she's diabetic, so this diabetes is not going anywhere. So this patient will need lifelong follow-up, because we know that obesity is associated with a 30-fold increased risk of endometrial cancer. So we need to assess this her condition. So lifelong follow-up. So answer for question number 28 is B, hysteroscopy. If they give you combined option, that will be wonderful, because you will like to do hysteroscopy and take endometrial biopsy. But if they are asking about the first step, hysteroscopy. Most useful investigation, endometrial biopsy. Any role of tranexamic acid? No. She needs contraception. Even better that you will give her levonorgestrel intrauterine system, Mirena. Any confusion, any problem here? Yeah, first, if they are asking you about the first step, then you will do hysteroscopy, and during hysteroscopy, you will take endometrial biopsy. Why I am agreeing for this answer? Because if you will take pipal endometrial biopsy, it is not going to be helpful, because you are supposed to visualize the cavity also, endometrial cavity also. So that's my take on this question. Yeah, so so that's a gray area. We are not going to assume that they will let us do hysteroscopy and then they will let us take the sample, okay? Because no place for people, though they are very helpful, but the new standard of care is that you have to see and take the sample. And if at that time, if you find polyp, you can remove it at that time, or you would like to do that inside OR. What do you think? Mm-hmm. Better to do inside OR, because you will not only remove the polyp, you need to take the endometrial tissue also. Okay, so better to do is that inside OR. You will be tempted to remove that in the outpatient. So if the patient is tolerating pain, everything is fine, then okay, you can crush the pedicle and you can take the polyp out. But if she is having heavy bleeding and she has risk factors, so it is always better to diagnose it now and arrange as a day case and take the polyp out and take endometrial biopsy. That is the point. So we will go for hysteroscopy. Then we will do other things, because endometrial biopsy I love to do that. but I will not like to do it blindly. I will not do it purple. I will do it under hysteroscopy. Okay. No, you should not take. First of all, you will exclude the local cause because 80% of such cases they will have vaginal atrophy, atrophic vaginitis. Okay, so 80% will have some local cause. If you don't see any atrophy or you don't see any breach in the epithelial lining, you will go for, in the next step, you will do hysteroscopy and you will take the sample. That is better. But you know, if the patient has one episode of bleeding, no local problem, then what do? We do transvaginal scanning, right? Transvaginal scanning, and then we will see that if the endometrial thickness is greater than 5 millimeter, then we need to do the scopy and we need to take the sample. And 21 to 40% patients, they will have a polyp. Polyp can develop in the postmenopausal women also, in the premenopausal and the postmenopausal. Both can develop it because it will be under the influence of estrogen, and even though she is postmenopausal, ovaries are not producing any estrogen, but still in the peripheral tissue, these androgens, they can be converted into estrogen, so patient will have some stimulus in the system. That is the problem. Okay, so scopy and you can remove the sample. And sometimes, you know, these postmenopausal women, they will have cervical stenosis. You won't be able to take the sample in the outpatient setting, so in that case again you are going to schedule endometrial biopsy, hysteroscopy and endometrial biopsy as a day case. Okay, do that now. Is that okay? Any other question you have regarding the same question? Okay. Okay, yes. Question number 29, 60 years old, osteoporosis in spine and osteopenia in hip bone. So what is the management? So now she has a clinical diagnosis of osteoporosis and osteopenia. So she's 60-year-old. So now we need to give her bisphosphonates, because if you will give this vitamin D and calcium, it will take a long time and your patient is already a diagnosed case of osteoporosis. So we will go for bisphosphonates. COCPs we will not give her, and calcium and vitamin D she can take as a supplement, but we need to give her definite treatment. Bisphosphonates, their indications, contraindications, they are available on the web page. Just revise the main points. It will take like just 5 minutes to revise that topic. So for the bisphosphonates, you know that what is the mode of action? They will slow down bone cycle, they will slow down bone remodeling. Okay, they will maintain they will basically increase osteoblastic activity and they will decrease osteoclastic activity. This is the action of the bisphosphonates. Question number 30. Pregnant patient being treated with the following drugs. Don't know for what. I guess had nephrectomy in childhood. Which one to stop? Aspirin, prednisolone, mycophenolate, mafetil. So actually she doesn't have to stop any of these drugs because the new evidence shows that even this mycophenolate, it is not associated with any congenital anomaly. Another observation was that it is associated with low birth weight and preterm delivery, but last year, no, in 2019 there was some article in the talk which said that it has no effect, but still RCPI didn't update us on that. So if they will give you the drugs, aspirin, you know, we are not giving in the start. It should be started at 12 weeks and or even at 16 weeks it can be started. Prednisolone, if your patient has you know, this autoimmune idiopathic thrombocytopenia or immune thrombocytopenia, then they will need this prednisolone therapy. Prednisolone, this is a glucocorticoid, so it is associated with chance of increased risk of what defect, cleft palate. Okay, but again you have to maintain a balance between the risk and benefits. If mother has some condition like most likely some autoimmune disorder, asthma, then she will continue taking prednisolone, because stopping the drug means more harm to the woman and her pregnancy, so she will continue taking that because the incidence of cleft palate is very low. So out of all these three drugs you need to stop mycophenolate. Then these drugs, they have certain washout period. Most of the autoimmune drugs, they have a washout period of 3 months. So methotrexate, and then if your patient was on calcineurin inhibitors like cyclosporins, mostly those patients with multiple sclerosis, they can be on these drugs. So these should be stopped. Then if your patient she has some hemoglobinopathy, then you need to stop hydroxyurea. In cases of sickle cell disease, you should stop it like 3 months before trying for the pregnancy. Then if your patient is thalassemic, you will have to stop defracirox and defrapiron 3 months before pregnancy. That's how you will continue. If she is taking treatment for epilepsy, change the drug to less harmful drug. If he was on polytherapy, you will switch her to monotherapy. So these interventions you need to do. Then for the diabetic, you need to control her. For any medical disorder for that matter, you need to improve her condition, improve disease control, and offer her effective contraception, and after that she can continue to aspire for pregnancy. Then another very important drug, if your patient has acne and she is using retinoic acid, vitamin A derivatives, then you need to tell them that their use is associated with high chance of neural tube defects, neurological defects like microcephaly can be there, eye defects can be there, ear defects, cardiac defects, liver problems, they are common with such drugs. So this is also an indication for termination of pregnancy. So whenever you are prescribing isotretinoin, vitamin A derivatives for acne, you need to do a pregnancy test. If pregnancy test is negative, then you need to give effective contraception to such women, and then you have to tell them that if they will conceive, then baby is going to have multiple abnormalities. As much as 50% babies, they can have some problem. So that's why they need to take effective contraception. So, and if they will conceive, then baby is defective, and then maybe they'll have to go for termination of pregnancy. Then you need to counsel your patient that vitamin A derivatives, they are meant to be used in cases of severe acne. If they give you a patient who has very mild acne, then you don't have to give anything, just give her benzyl peroxide. These benzoic acid derivatives, they are pretty safe even if she becomes pregnant. If she says that no, she doesn't like her appearance, so she will need something, you can give her many other things depending upon the type of acne. Okay, like if she is not taking any precautions, still you can give her clindamycin because it will not cause any abnormalities. You can give her topical erythromycin. Okay, these are not associated with any teratogenicity, so the patient can use that. Or vitamin A derivatives only if she has severe acne, like acne vulgaris, and you need to tell your patient that it is going to cause excessive dryness of the mucous membranes. She can have scalp irritation, she can have severe alopecia, and she can have nose bleeds also, and then she can have dry lips, dry mouth, dry oral mucosa. So these are really bad effects, especially they can have excessive hair loss. So these drugs have to be used as a last resort, not as the first therapy. So sometimes they will give you a scenario where you will have to counsel the patient that since she has very, very mild acne, so retinoids are not even recommended. Then they can ask you that patient has used vitamin A derivatives, isotretinoin ointment, so when she can safely plan a pregnancy. previous recommendations were the most previous one, that she should wait for 1 year. Then they said that she should wait for 3 years. Then in 2014 they said, by they mean I mean federal food and drug agencies, they said that patient should wait for 1 month after stopping the treatment, because during 1 month all of this drug will be washed out of their system, so then they can plan a pregnancy. So that is the point. Okay, so these are the harmful drugs. Many other drugs are there, but but this was a brief description. We need to talk about the other drugs also, so we will do that. Okay, then this is another question. Patient 31, question number 31, pregnant patient with illicit drug use, which one is the most dangerous? So we just talked about amphetamine because of its vasoactive substances. And the second thing is that since they are cooking these drugs, designer drugs, they are adding many things, even acid, even silica. By acid I mean this LSD, lysergic acid, which is also a drug of addiction. So they are combining drugs, so very harmful effects on the baby. So if I ask you about another drug which you can add here, that will be cocaine, because cocaine can also, it also has vasoactive properties, so it can cause defects in the babies, because how does a baby develop? First, a blood vessel will be formed, and around that blood vessel the organs will develop. So since it has vasoactive properties, it will cause vasoconstriction, decreased blood supply, so hyperplasia can be there. Okay, so that's why we should be careful. Then you should remember that if the patient is taking cocaine, it can cause placental abruption. Then related to IUFT, if your patient will stop methadone suddenly, then it can result in an IUFT. Just remember these points because they like to ask such questions. Okay. So question number 32, patient at 12 weeks gestation with SLE taking infliximab, and now she is in remission. When to stop? So immediately at 12 weeks you are not going to stop, because as we have read that the transport of the transplacental transfer, it increases after 20 weeks and highest transfer after 28 weeks of pregnancy. You will not stop the drug immediately, and we have read about this one, that infliximab, it should be stopped between 21 to 22 weeks. So at 28 weeks and see at term. So if your patient's condition demanded that you should continue giving her drugs, you will continue giving her this thing, but this is the last limit. At 28 weeks you are going to stop all types of biological agents. So yesterday I read another question on SLE. They gave full description of SLE, but they didn't write the word SLE. They gave that this patient has suffered multiple miscarriages in the past, she has history of PET, she has some problem and her joints are stiff, and she has like this migratory joint pain, like that. But they didn't write this rheumatoid arthritis, and otherwise also rheumatoid arthritis patients, they will have joint stiffness in the first 3 or 4 hours of the day, and then they will start gradually this movement. But this patient had stiffness and pain throughout the clock, like in all 24 hours. So then your answer is you will go for SLE, because SLE is basically treated by the rheumatologist. SLE, Sjogren syndrome, ankylosing spondylitis, then this one rheumatoid arthritis, all varieties, these are treated by the rheumatologist. So then we should go towards that diagnosis that patient has SLE. And you know that SLE patients, like 10% of them, they can have antiphospholipid syndrome also. So then sometimes they can give you another scenario in view of the same problem, that patient has SLE. Then they will say that patient is unable to get up in the morning because she has lower back stiffness. So then your answer is ankylosing spondylitis, and it is associated with the genetic makeup, when your patient will have HLA-DR-B27, that will be positive. So that's how you are going to remember the things by comparison. So this patient, since we didn't stop anything for her before, we should have stopped at 21 to 22 weeks, which we didn't. So now we have reached the blockade at 20 weeks, 28 weeks we have to stop. That is the point. Okay, so all of this information is given in the notes on biologics. Okay. Question number 33. Ovarian mass, breast tenderness, estradiol 200. So again granulosa cell tumor. Be sure you are going to see granulosa cell tumor again and again. So, but you should know about the diagnosis and management. Question number 34. Severe premenstrual syndrome. Patient has severe symptoms in the second half of the cycle. She is newly married, afraid that it will affect her relationship. So, what should be given? Second half fluoxetine. This is SSRI. But do we give fluoxetine anymore? We give citalopram and escitalopram. It is given here. This table is new, the question is old. Okay. So first of all, what is the definition of premenstrual syndrome? Can you tell me what is the definition of PMS? Any one of you? Do you hear me? What is premenstrual syndrome? You all know about that. Every day you are getting patients. So premenstrual syndrome, when your patient is experiencing certain symptoms which cannot, and in the absence of any organic disease, and where he can have these symptoms, he can have disorder in mood, and she can have in the behavior, and she will have such variations. She will be so upset that it can result in increased number of accidents. Okay, so what is the incidence of PMS? 5%, 5 to 8%. So 1 in 4, but 5 to 8% they will have severe PMS symptoms. Okay, so then they have introduced many different varieties of PMS, premenstrual syndrome. They have divided them into many different disorders. So then if the patient comes to you and she is giving you history of irritability, depression, she have psychosocial, physiological, and she's upset about these things, and then it is interfering with her personal or professional life, and in the absence of any organic disease, and it occurs in the last week or during menstruation, and it disappears. The symptoms are at its peak before starting this menstruation, and with onset of menstruation her condition starts improving. Okay, that is the full definition for this one. So then they have how do you assess? History is very important. You have taken the history, then you will give her a menstrual diary. This is a prospective diary. Like if they will recall, they are going to have a recall bias. So that's why you are asking her to record daily record of symptoms prospectively for 2 months. So then you will say that you can diagnose PMS. So then you have to know that these symptoms are cyclical, and then they are relieved by menstruation, and patient is having a symptom-free week also, and no influence on quality of life. Like this is a spectrum that how many problems your patient can have, and patient doesn't have any additional factors. Okay, so what should be done? This is physiological or very mild menstrual disorder, so just offer counseling and reassurance is required, and no need for any treatment. Now patient has come to you, she has recorded her symptoms. Symptoms are cyclical and relieved by menstruation. She has symptom-free week, affects quality of life, and menstruation is there but no additional factors. Okay, like she's having phases like that. What should be done? She has core premenstrual disorder or premenstrual syndrome or premenstrual dysphoric disorder. Like patient is just feeling unhappy in the premenstrual period. So consider all alternative appropriate and approaches to the treatment. That can she have any alternative diagnosis? No, then we are going to treat her. Then a third patient who will have cyclical symptoms relieved by menses, and she has no symptom-free week, and it is affecting her quality of life. First one was not affecting quality of life, but all of them they are affecting the quality of life. Then you need to see that patient is have menstruation is fine, but existing non-menstrual condition. So what should be done? So this patient has premenstrual exacerbation. So treatment should aim to treat underlying medical, physical or psychiatric condition, or suppress ovulation, or in some patients you will have to combine both of these things. Then a fourth group is patients exhibiting cyclical symptoms, symptom-free week is there, quality of life is affected, and they have no menses and no additional factors. So they have premenstrual disorder. Premenstrual disorder can be there with absent menstruation also. Don't think that if patient is amenorrheic, she cannot have any problems. So treat as a core premenstrual disorder. Okay, this algorithm is for the diagnosis. Then the fifth group, it has patients who have cyclical symptoms relieved by menses, symptom-free week is there, quality of life is affected, menstruation is there, and they have received progesterone treatment for some other disorder. Then you will see that these patients have progesterone induced premenstrual disorder. So you will not stop progesterone, you will give her alternative progesterone treatment. Give her a low progesterone with low side effect, low potency. Okay. Then patient can have non-cyclical symptoms, no symptom-free week, constant influences on quality of life and menstruation, and no additional factors. So this is, you have to treat the underlying psychological disorder, and then this is not a premenstrual disorder. So psychiatric referral. Which patient? No symptoms are non-cyclical, no symptom-free week, and constant influences on quality of life. She has menstruation, she has no additional risk factors, so it means she should be sent to the psychologist, psychiatric referral only for this patient. Then how do we treat it? You don't have to go and remember all details, this info is sufficient. First line treatment, exercise, cognitive behavioral therapy, give vitamin B6 which is pyridoxine. Then combined new generation pills, you can give them cyclically or continuously. If the patient has severe symptoms, you can do tricycling, give for 3 months and then stop this drug for 1 week so that they will get menses. Then another option is to give continuous or luteal phase like day 15 to 28 low dose SSRIs like citalopram or escitalopram. These are newer types of SSRIs and they are more efficient. Okay. How much? 10 mg. This dosage is important because first line management 10 mg. Your patient didn't benefit, you did re-evaluation, you will go to the second line management. Offer estradiol patch. Before they used to give 200 microgram patch, but then they realized that same benefits with 100 and 200 microgram patches, but more side effects with 200 microgram patch. So estradiol patch plus micronized progesterone patch which will contain 100 to 200 mg, and it can be applied from 17 to 28 days. Then patient can take all of these things orally or vaginally also, or you can insert LNG. So estradiol patch is there and then you are giving orally, vaginally or intrauterine system. Second option is if patient doesn't want combined therapy or she has some contraindication, then you have the option to give her higher dose SSRIs continuously or luteal phase. Again citalopram, escitalopram, but before 10 mg, now 20 to 40 mg. Patient has benefited, well and good, you can continue this therapy. Third line, if the patient has not benefited from these interventions, give gonadotropin releasing hormone analogs plus add back HRT like continuous combined estrogen plus progesterone. Now the dose, you see, before it was 100, now you are giving 50 to 100 micrograms estradiol patches or 2 to 4 doses of estradiol gel combined with micronized progesterone 100 mg per day, or you can give tibolone. They will not ask you about the doses, they will just give you the name of the drug, so easier for you. Patient has not benefited, then we are going to offer surgical treatment, which will be TAPSO. But you need to tell the patient that even by doing it, her condition may not improve. And then you will have to give her hormone replacement therapy till the age of menopause. Any question, any problem about it? You know, the incidence is 5 to 40%. The for this premenstrual syndrome, the incidence is 5 to 40%, but okay. So your patient, but 5% they will have a severe type of this one, premenstrual syndrome. So I think we can stop here today, and tomorrow we will resume from here. And if you have any other questions, please write them down, and then we will start with discussion. So same time tomorrow, like 2 p.m. KSA time. So okay then, see you tomorrow. Okay, take care. Welcome. See you tomorrow, inshallah.